मेरी बैचमेट से अंजू से शादी हुई है इनकी, सो हम इनको बैच के जीजा
हाँ
जी
तो
बोलते
इसलिए और टेंशन आ रहा था
और
कि
सुनो, बेस्ट थिंग इज कि अंजू भी इनको सर ही कहती है।
ओह सो स्वीट। हाय डॉक्टर आरती।
Hi, good evening. Good
Happy New
evening,
Year.
Chandravati ma'am.
हैप्पी न्यू ईयर आरती।
नीलम मैम गुड इवनिंग।
गुड इवनिंग नीलम मैम।
अंचल, ओली सर, एवरीवन, कंचन जी, सबको
Hi,
गुड इवनिंग।
Neelam. Good evening. So good to
And
see everyone.
Amit is also here. Madhuri is here. Hi Amit, good
Hi,
evening.
good evening. And I wish
I
you
am here.
all a
I
very
am here.
happy new year.
हैप्पी न्यू ईयर अमित।
Happy New
Oh,
Year.
madam, namaste.
होने वाले फ्यूचर प्रेसिडेंट नमस्ते।
Hi Madhuri, thank you so much. Everybody is here and please मैं पहले ही माफी मांग ले रही हूँ, कुछ गड़बड़ वड़बड़ हो तो माफ कर दे।
माफी ऑलरेडी गिवन, अब तुम जितनी चाहे गलतियां करो।
मैडम वो
Still love you. We still
मैडम वो
love
कोर्ट
you.
में कैसे एंटिसिपेटरी बेल लेते हैं ना, वैसे
हाँ,
उससे
हाँ वो
माफी मांग ली।
एंटिसिपेटरी वही चल रहा है, सीमा वही लेके बैठ रही है, कुछ भी हो कोई बोले ना कुछ भी।
नहीं, आप कितनी भी गलती करोगे, we still love you. ऐसे बोलने का उसको.
Love and hugs. I'm so privileged.
All the best to you, and I'm sure you will do well.
Hi Dr. Amit.
Hi, good
Hi,
evening.
everybody.
Dr.
Hi
Sujata.
Dr. Sujata.
Meeting was here. माधुरी किधर गई?
I think Madhuri ma'am was, entering her apartments. I know the apartments bars. I've gone to her house.
How's
She's
your
now
throat
in the
now,
lift.
Sujata? How are you feeling now?
Not good.
Arey, what happened?
She is having bad throat.
Flu.
Everybody at home, very bad throat and khasi and no fever, but
Yeah,
generally bad.
I had it last week. After 3 days, I started azzy and I started feeling better. There was no fever, just runny nose and headache.
Yeah,
Tiredness, correct.
bad, very bad.
Are you guys testing for COVID if it's
No.
bad too?
No.
No way, no way.
Because some of the cases are being reported again.
Hi Aradhana, Akriti, good evening.
Sujata ma'am, Amit sir,
Hi.
Hi, good evening.
Shweta.
राज को पता नहीं मैंने हाय बोला कि नहीं।
तूने मुझे कर लिया सुबह से 4 बार, टेंशन मत ले तू।
Neelam is looking so serious.
नीलम मैम सोच रही थी आज शी इज लाइक कि आज मैं बहुत अच्छी नहीं दिख रही हूँ, लेकिन तुम बुला रही हो तो मैं आ रही हूँ।
She looks as pretty as always. नीलम
Yeah.
I know.
नहीं मैंने लिपस्टिक इसीलिए लगा ली कि शायद
मैंने भी।
आ जाए।
Hi, Dr. Neelam.
Hi.
Hi, Hi, Dr.
मेरा हाल देखो इधर क्या हाल हो रहा है।
Hi Radhana ma'am. It's very cold here in North India. We are
Acha.
9 degrees. 8 degrees.
मजा आ रहा है, पहली बार तो ठंड थोड़ी सी आज।
हाँ यहाँ भी
is cold,
यूपी में भी उतना ही है, यहाँ लखनऊ में भी ठंडा है, सब जगह ठंड है।
हमारे यहाँ
किसी
तो
का सीमा वेट कर रहे हैं किसी का।
हमारे यहाँ तो एसी चल रहे हैं।
आई थिंक अब
8:03
गड़ा
हो गए।
सर गुड इवनिंग, प्रणाम, थैंक यू सर।
Good evening, Gada sir. Good
Thank you so
evening.
much, sir.
Good evening, Gada sir.
Dr. Dheeraj Gada sir.
Sir,
Good
unmute
evening.
कर लीजिए sir.
Good
Unmute
evening,
कर लीजिए.
sir.
Good evening, Dr. Gada sir.
गुड इवनिंग
Hi, Aarti.
Hi. Good to see you.
Sir is
Anuradha,
looking-
hi.
Hi, Aunty.
Hi.
Hello. Hi, Kanchan ma'am.
Hi, Anuradha. Radhna.
Yeah.
मुझे लगता है कि हम लोग शुरू करेंगे तब तक हमारे बाकी गेस्ट आ जाएंगे या।
हाँ शुरू कर दो सीमा।
यस मैम मेहुल।
Okay, ma'am. We are starting. Is it visible, ma'am?
Yes, it
Hello.
is. Yes, it is.
Yeah. So, I, Mehul Doradia, on the behalf of Corona Remedies Private Limited, I welcome all the delegates and faculties for the Core Connect live webinar organized by UP chapter of Hisar in association with MP Hisar, Uttarakhand Hisar, and Azamgarh Obs and Gynae Society. This webinar is on an evening with all the Hisaricians. So, first of all, it's my privilege to welcome our MOC, Dr. Raj Lakshmi Valavalkar. She is a medical director of Cocoon Fertility Center and Eurofem Pelvic Healthcare. Madam has achieved so many degrees, not only from India but from UK also, as well as from USA and Eurogynae from the Germany. And this madam is the assistant secretary of CGP IMA Thane, as well as chairperson of RCOG India License Group. Madam achieved so many awards like Times Power Woman Award, Times Unlimited Entrepreneur Award, Times Health Excellence, and IMA President Award, Excellence in Fertility Care also. So, welcome, madam. And I hand over the session to you and requesting you to please proceed this webinar.
Thank you so much for the warm welcome, sir. Ladies and gentlemen, and our esteemed guests and distinguished Isarians today, a very warm welcome to an enchanting evening on the momentous occasion of an evening with Isarians. This is a seminar which has been crafted with great care and passion by our UP chapter and its beloved President Dr. Seema Pandey in collaboration with MP Hisar, Uttarakhand Hisar, and the Azamgarh OBGY Society. Tonight we will embark upon a journey of knowledge, of shared wisdom, especially surrounded by the esteemed luminaries of Hisar. In the tapestry of medical excellence, we are today going to find ourselves bound together in our exploration of the field of reproductive medicine. The flickering flame of the lamp that we will be lighting soon not only will symbolize the illumination of knowledge, but the synergy that exists within our community. And as we embark in the glow of this ceremonious light, let us be reminded of the sacred duty we shoulder, a duty to advance the frontiers of knowledge and nurture the spirit. With this, I welcome all of you to join us in a little prayer and lighting of the lamp ceremony. Thank you. I'll request everybody to join your hands, please. Okay, so having prayed for a successful start and completion of the CME, I will take this opportunity to introduce Dr. Seema Pandey, the esteemed president of Azamgarh OBGY Society. Seema is our distinguished colleague who has strived towards excellence in women's care. even in a small place like Atrolia, where she has brought the best of the best treatments to her patients locally. Her unwavering commitment towards advancing women's health and her vision towards bringing the best both academically and clinically are what make her such a asset to ISAR, in my opinion. It is with my utmost admiration, she is of course my best friend, that I will like to extend a warm welcome to her so that she can invite and introduce our chief guests for our CME this evening. So I hand over to Seema. Seema, please take over.
Thank you, Raj, for such a kind introduction. Namaskar. Good evening, my respected esteemed seniors and dear friends. I feel proud and privileged to welcome all of you for this evening. And I think some of our chief guests are not here. I will start with people who are here and then we'll keep introducing. So this evening with ISARian was a concept so that all ISARians meet with each other, greet each other and learn from each other. So on this note, I would like to welcome our incoming president, Dr. Amit Patki. It gives me an immense pleasure to welcome you, sir. And Amit is a very good friend and a mentor. And I'm really thankful that you have accepted my kind invite. Dr. Amit is Medical Director, Fertility Associates, Mumbai. He is Honorary Associate Professor, KJ Somaiya Medical College and Hospital, Consultant, Khar Hinduja and Surya Hospitals, Khar, Mumbai. Amit is Country Representative, Aspire 21-23, Governing Council Member, ICOG 2012-21, President-elect ISAR 2022-24, General Secretary MSR 2018-21, Chair West Zone RCOG 2015-2020, President MOGS 2014-15. Amit has 35 publications in national and international journals, and he also has 50 book chapters and editor of 3 books. And I was fortunate enough to work with Dr. Amit, and I know how meticulous and wonderful he is with academics. 2 international patents in infertility and stem cell research. We are so proud of you, Dr. Amit, and he's also our TDX speaker. I welcome you, Dr. Amit Patki, and I'm looking forward for a wonderful year ahead. And I would like you to just share a few words of wisdom, sir.
A very good evening to you all. And at the onset, I would like to thank Dr. Seema for having invited me to the first webinar that I'm attending in 2024, an evening with ISARians. I'm also very happy that it is a collaborative effort of UP, MP ISAR, Uttarakhand ISAR with Azamgarh OBGY Society. And I want to see more collaborative efforts, because that is the way we will get the true talent from all our ISARians. I look forward to having all of you in our annual conference at Bhubaneswar, 2nd to the 4th of February. And I wish Dr. Seema Pandey the best of success in her future endeavors. And I'm sure she will do well. And thank you once again for having me part of this very academic and interactive meeting. So best wishes to you, Dr. Seema. And I'm so happy to see so many familiar faces and seniors, and my pranam to all of you, and a very happy 2024. Thank you very much.
Thank you so much, Dr. Amit. And it is really nice to have you around. Now, before I go further and welcome my next chief guest, there is a small correction. Friends, I am president of Azamgarh Obs-Gynae Society, not the chairperson of UP ISAR. That is our beloved Dr. Neelam Hori ma'am. So yes, now I really feel honored and privileged to welcome our Legion Past President, Dr. Dheeraj Gada, sir. Thank you, sir, for accepting my humble invite, as you were not in very pink of your health, but you are still here. I'm so grateful, sir. Thank you so much. Sir was President ISAR in 2003. He is first Indian to represent at international level, and sir has successfully organized 22nd World Congress of Fertility and Sterility, IFFS 2016, recently in New Delhi. And sir has been honored by Lifetime Achievement Award by Indian Society for Assisted Reproduction and Indian Fertility Society for his contribution in reproductive medicine. And sir is the first gynecologist in state of MP to bring laparoscopy and first to bring hysteroscopy. Sir is also, he has so many first in his name, including ultrasonography, assisted reproduction, and IVF in his country. Sir had many publications and has delivered large number of orations and guest lectures. Thank you, sir. I welcome you, and I would love to hear few words from you, sir.
Thank you very much, Seema. It's my proud privilege that we are starting 2004 with a very nice organized webinar, and I wish the big success to this webinar. And I'm sure that many more webinars will be coming. Corona has taught us one thing very nicely, to learn online, to practice online, and we are doing it very well on this ground. And this is a much better way than traveling long distances and attending various conferences. You have done excellent job, and all the best. And my all best wishes to Amit for your next endeavor as a president. We will all enjoy Bhubaneswar. Please do come to Bhubaneswar. Thank you.
Thank you very much, sir.
Thank you, sir. Thank you so much. Now, friends, I really take pride and privilege in introducing a teachers of teacher, my favorite mentor and mentor of so many people around here, our own Professor Dr. Chandravati ma'am, who is Professor Emeritus, Department of Ops and Gynae, KG Medical College, Proprietor Director, Krishna Medical Center, Lucknow, Managing Trustee, Krishna Educational Foundation, Lucknow, Secretary, NGO, Wheel Women Health Empowerment and Education, Lucknow. Ma'am is Patron, Indian College of Maternity and Child Health, ICMCH, NARCHI, LOGS, APGL, IFS UP Chapter, UPCOG, Private Nursing Home Association, Lucknow. Ma'am was HOD Department of Ops Gynae, KGMU, and she was my examiner too. I keep reminding ma'am, and she was really nice. Ma'am has been Vice President Foxy 2001 to 2002, UP Chapter Ops in Gynae, Lucknow, and Ops Gynae Society for 15 years, Governing Council member ICOG for 2 consecutive terms. Ma'am is peer reviewer Journal Committee ICOG for 5 years, and ma'am has organized more than 20 state, national and international level conferences. Thank you, ma'am. Thank you so much for accepting this invite and be among us. Ma'am, please, we would like to just listen few pearls of wisdom from you, ma'am.
Thank you, Seema. It is a pleasure really that you have thought of calling me, and I couldn't say no to, because I would have really missed this pleasure of meeting each one of you. It is a wonderful name which you have given this evening with Isarians. It is a very Bollywood-like title which you have created today, and I welcome all the office bearers, national office bearers, ISAR of MP, of Uttarakhand, and UP ISAR office bearers. And Seema, I wish you all the luck that you have taken so much of trouble of organizing this webinar. And I'm sure that this webinar is going to go to a great success with so many learned speakers and people who are participating into it. I wish you all the luck, and in near future, I'm sure you are going and arranging many more such webinars. You people will be doing it. And it is pleasure to see all the office bearers here today. Thank you again and again for inviting me and be part of this wonderful webinar today. Thank you. Wish you all the luck and all the blessings from my side. Thank you.
Thank you so much. It means a lot. Friends, our two dignitaries, our chief guest, President ISAR, Dr. Nandita Palshetkar, and Vice President Dr. Sunita Tendulwalkar, they are not here yet. Whenever they are, they'll be here. We will be welcoming them. Till then, I'll give this further over to Raj. Hello,
Hi, good
Raj.
evening again, everybody. With that, I will like to now invite and pass on the baton to Dr. Anuradha Khat, who is our dear IVF consultant from Bangalore. And she carries the torch of what ISAR stands for with her expertise and her experience. And I will like to invite her now to graciously extend our heartfelt invitation to our revered guests of honor as we start on this evening. So Anu, kindly please invite our guests of honor for us. Unmute yourself. Unmute, Anu.
Sorry. Good evening to all the experts, all the faculty, and all the members who have logged in for today's program. ISAR is very close to all of us, and we know that. And thank you, Dr. Seema. Thank you, Azamgarh Society, for giving this opportunity. And I would like to invite our first guest of honor, Dr. Madhuri Patil, who is from Bangalore. And I would like to invite Dr. Can you please display? Yeah. So Dr. Madhuri Patil.
Nandita join, please. Introduce her first, then I'll see.
Dr. Seema, can you invite Dr. Nandita first, please?
I was just calling Dr. Nandita only. Yes.
Sorry, there's some signal problem. I'm in the car.
Okay, I thought that you are not able to join, so I was sending the link. And welcome, ma'am. And I feel proud and privileged to welcome our beloved President ISAR, Dr. Nandita Palshetkar, who has also been past president to FOXI and all the other organizations I am aware of. Thank you, ma'am, a mentor and a dear friend. She has been bestowed with the fellowship and if I'm sorry if I'm not able to read it correctly, and UNDEM and Honors Causa from Royal College of Obstetrics and Gynecology, RCOG. Ma'am is an eminent IVF specialist with more than 28 years of experience. Dr. Nandita is medical director, Bloom IVF Head Centers, 7 centers all over India. She is an specialized.
Thank you.
She has so many awards and accolades to her name, and we are really, really privileged to have her guidance and leadership. I welcome you, ma'am, and I would just like that you just share a few words from your side.
Thank you, Seema. I think it's a pleasure to be on the same platform as Dr. Chandravati, always been a mentor to all of us and fantastic. And Madhuri, thank you for noticing that I had joined. Madhuri is always a protocol person and very sweet of her to to point that out. But Seema, congratulations. I think this is a fantastic endeavor. And, I have spent 2 years in ISAR, and there have been so many programs and so many people who have worked so hard. And I think you are one of them. So thank you very much and keep up the good work. And I'm so happy to see everybody's faces here. I think I can see Rakhi, I can see Neelam, I can see Anuradha. Yeah, she's waving out over there. Then Kanchan is there. And Sujata. Oh, Sujata, hi, how are you? Okay, and I think everybody is here. Monica is also here. That's really great. I think you've all the stalwarts of ISAR are here. I can see Yatinder, and I'm not going to go on, otherwise I will just be taking names. But I think, it's very important that uh, infertility is a very distressing part of a woman's life. And if we have more CMEs like this, I think that will really change the patient care. And every person who comes for a talk, believe me, does a lot of work, does a lot of studies, and uses these studies along with the experience of that person. So I think it really benefits everyone. In fact, whenever I listen to anybody giving a talk, I think I learn 1 or 2 points which makes a difference in my practice. And I think that is the importance of a CME, where eventually we'll end up making a difference in our patient management. So great job, Seema. All the best in your endeavor. And I'm so glad to be here, but I am traveling on the road, as you can see. So I don't know how the signal will play, but really great to see you. I think Rakhi is also here. Yeah, I can see her now. Okay, thank you very much. And Madhuri, the stage is all yours.
Thank you
Thank you,
so
Seema.
much, Nandita, for making it. And please have a safe travel, and we'll see you soon.
Happy New Year to everybody. Okay,
Happy
thank
New
you.
Year.
Thank
Same
you.
Happy New Year.
Bye.
Happy New Year, ma'am. Happy New Year, ma'am.
Yeah, bye.
Bye.
So we will now start again by, inviting our guest of honor. So Dr. Madhuri Patil, I would request you to display the CV. Dr. Madhuri has been my mentor. My first baby steps I have learned with her in her center. She's from Bangalore. I mean, she's basically from Maharashtra, but has been practicing here. She's the clinical director of Patil's Fertility and Endoscopy Clinic, Bangalore, associate editor of Fertility and Sterility, a journal which we all read and revere. And she's chairperson Aspire SIG Reproductive Endocrinology. She's the current chairperson, president founder of Fertility Preservation Society of India, vice president PCOS Society, and she's a founder member of that, vice president Indian Society of Assisted Reproduction. She's the current VP and board member AEPCOS Society, governing council member ICOG, member education and accreditation committee Aspire and Aspire SIG, associate editor of Oncofertility Journal, past editor chief of our Human Reproductive Sciences Journal, and she has received a Lifetime Achievement Award from ISAR, Dr. Duru Shah's Award, Vidya Bhushan Award from ICOG in 21. She is our Karnataka chapter of ISAR. She's the founder chairperson and principal and course coordinator and examiner for fellowship and certificate course in reproductive medicine from our RGUHS Karnataka. And she's member of International Reproductive Medicine Research Network. I think whatever I say, it will be less. She's academically so good. Whenever we have problems, we always move towards Madam and ask her our, doubts. So welcome, Dr. Madhuri Patil. Now, would you like to speak few words for us?
Thank you, Anuradha, for that introduction. I think there was no need because everybody knows me. And Happy New Year to all of y'all who are here. And I think this is a very good endeavor and initiative which has been taken by the MP Rajasthan UP chapter together. And I think today's topic is very, very relevant because we know that PCOS is now one of the most commonest conditions which we see in infertility. And I think it will be a lot of learning. We always think that obese patients are more problematic, but today's webinar will tell us that it's both lean as well as obese, which need to be treated. And I think lifestyle modification is required for both of them. And I think I wish Seema, Anuradha, Shweta, all of y'all who are going for their contesting, as well as Sujata, who are contesting for the elections. And I'm sure they'll come out with flying colors. And I wish all of you all best of luck.
Thank you, ma'am. Thank you, ma'am. Our next guest of honor is our own Dr. Sujata Kar, who is our present secretary of ISAR. We all Can you display the, yeah, she's from Orissa, Bhubaneswar, and she's a practicing gynecologic endoscopy and assisted reproduction for the last 28 years. She has special interest in PCO, proteomics of male infertility, and stem cells in gynecology. She has received Best Graduate with 7 gold medals in MBBS MD, credited with first IVF baby of Eastern Orissa, first TISA frozen embryo laser hashed babies of Orissa. The awards, Parichay Award for Women Achiever Odisha from the government of Orissa, Devi Awards for Dynamism and Innovation from CM of Orissa, Brand Icons Excellence Award 2018 for Best IVF Center in Eastern Orissa. She has 18 original publications related to PCOS and male fertility in PubMed, written many chapters for books and newsletters, reviewer of many international journals. So she is our Honorable General Secretary right now, and she's the EC member of PCOS Society of India. Welcome, Dr. Sujata. Please share your views and please speak few words for us.
Dr. Sujata, I'll just take a few minutes and
Yes.
Dr. Sujata will speak. Before she speaks, friends, let's welcome our chief guest, Dr. Sunita Tendulwadkar, our Vice President, ESAR, and President-elect FOXY 2025, Founder President Society of Ovarian Rejuvenation 2023, President POGS 2021-2022, Chairperson, Founder Honorary Secretary ESAR MSR, and President IAG 2019-2020, Vice President West Zone FOXY 2015-2017, elected board
Hello,
member.
Seema. That's enough. That's enough, Seema. It's honor to be in your webinar.
Thankful for you to accept the invite, ma'am, and join and be here. And we would love to hear a few words from you, Dr. Sunita.
Hi. No, it was a little bit rude or odd for me to cut Sujata. I just entered the home. I was traveling and that's why I could not join the webinar earlier. All I can see are my dear friends in your webinar. You have a star-studded webinars, the consultants of ART, all my great friends. And it's so pleasure to be with you all. I can see Aarti, Anuradha, Shweta, Ajal, Raj Lakshmi. You have reduced like anything. I can't even recognize you. Kanchan, Dr. Upendra sir, Sujata, dear friend, Monica, Ekika, Madhuri Patil, Diksha, Rakhi, Ranveer, the great boss, Asha, Aradhana, Neelam, and so many. I can't take so many names over here. But what is most important is the topic which you have selected today. The PCOS is most needed topic. And I think if whatever amount of webinars we have it, PCOS remains always, something different you have learned, you have heard. So whether it is lean PCOS versus obese PCOS, whether the contraception in PCOS or whatever you think about, it is always going to be different. There will be a learning to it. And I'm sure with so many ART consultants across the globe, across the country, you are going to rock today with your webinar. I'm looking forward to it. And Sujata, I'm sorry I joined little late. Thank you.
Thank you, Sunita.
I'm hoping to see you all in 2 days in Hyderabad and in another month's time in Bhubaneswar. All of you, Monica, Randir, they have raised the bar of ESAR at Bhopal to another height. And I'm sure Bhubaneswar will be yet another most memorable conference. And we all will be meeting each other and academics and fun together. Let's educate ourselves. Thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you so much. So I now go back to Dr. Sujata, ma'am. Please share a few words.
Hi,
Rakhi. Thank you. Good evening, dear all. Dear friend Sunita, it is hardly an interruption. It is a
No,
pleasure that
yeah.
I saw you also. Otherwise, we don't get to see each other, even in webinars. You being so busy, and I am not so much in all webinars and Foxy and everywhere. So anyway, Seema, thank you very much for inviting me in this star-studded evening. As you all said, I think almost everybody from ISAR is there, and it's a pleasure to be here. Welcome to all of you to Bhubaneswar in another month's time. And I really hope that we will be able to keep up to expectations. And also, I hope we will be able to set yet another bar after 2008, when most of my old dear friends will remember that we had hosted a fabulous ISAR conference in the same venue at that time. So really looking forward, and thank you very much for having me here to get an opportunity to be seen before the actual elections for the ISAR start. otherwise, in case people would have forgotten me. So thank you very much for this opportunity. I hope and look forward to your support. Thank you.
Yeah. Thank you, Dr. Sujata. I would now invite Dr. Raj. I have some technical problem with my Zoom. I'm not able to see the screen. Can you please introduce Dr. Asha Bakshi if she's there? And if she's not there, Dr. Neela Mori. Raj.
I am here. I am here. I'll be
Dr.
doing
Seema,
it.
I'm not able to see the screen. Let me sort it out. Sorry for that.
I am here. I'll be doing it. I wholeheartedly welcome and feel proud in introducing our next guest of honor, a very dear friend, Dr. Asha Anil Bakshi. She is lead consultant at Dr. Asha Bakshi Fertility Center in association with
Seema,
Motherhood.
just keep it very short. Just keep it short and crisp because you've got a long way to go.
Okay. So
Yeah,
Dr.
yeah.
Asha has so many things to her credit. She is founder chairperson MP IAG MP ISAR. She is chairperson of Foxy Infertility Committee 2017-19, member of ICOG Governing Council. To her credit, there is first ICSI, TCXI, Micro TCXI babies of MP. And Dr. Asha is recipient of Dr. Kumud Damaskar Award Foxy 2008-2009 and Best Paper in Foxy Journal. She has organized many conferences like Star Endogyne 2019, Icon 2017, ISAR 2016, and joined organizing secretary of IFFS 2016 and AICOG 2022. I welcome you, Dr. Asha, and we would love to hear a few words from you. And
Thank you
for
very much.
accepting my invitation, our invitation.
Thank you very much, Seema, for the kind introduction. And I'm so glad to see so much hustle bustle in ISAR. Recently, you can see so many webinars and everybody is taking a lot of interest. And I think this is what we want, and keep the spirit going. And I'm sure whole year the activities should be like that, so that we connect to each other, we learn from each other, and the topics are very good. And every webinar, I'm sure there are so many things to learn. And today, especially PCOS, which is close to everyone's heart, and it's a very good topic, and the lean PCOS that you are going to talk upon and all the things. So I'm very happy that you have selected this topic and you have involved everybody. All the stars of ISAR are here, and all the people, Dr. Sujata, you, Dr. Shweta, Randir, Monica, all, Anuradha, all of you are contesting, and I wish you all the best. And I'm sure you are going to do well. And once elected, you'll even you'll go beyond our expectations. So that's what I expect from you. And once more, best wishes. And I think we should continue with the webinar rather than wasting a lot of time.
Thank you, Dr. Asha. I would now like to invite Dr. Neela Mori, who is our next guest of honor. Please, can I have the CV, please? Dr. Neela Mori is in Varanasi, and she She is the medical director of New Life Hospital and Advanced Fertility Center, Gynec Endoscopy and Embryology Training Center. She is the current chairperson of ISAR UP, and she is the vice president of Varanasi Menopause Society, past presidents of Varanasi Gynec OBG Society, president New Life Foundation, 5 publications in national journals, various chapters written, and she's a peer reviewer of our JOGI, Journal of Obstetrics and Gynae of India. Organized many national conferences on infertility, gynae, endoscopy, fetal medicine, menopause, and many live gynec endoscopy workshops and hands-on IUI and ultrasound workshop. Welcome, Dr. Ori. Please speak few words for us.
Thank you, Dr. Anuradha, for such a kind introduction. And thank you, Seema, for inviting me here. It's really a very nice evening with all the ISARians, and a very happy new year to all of you. And it is always a great pleasure to be with ISARians. And today you have chosen such a nice topic, and we know about PCOS. The more we study about it, know about it, we think that less we understand about it. So I wish all the best for all the contestants, Seema and Dr. Sujata, Anuradha, Aradhana, everybody. And I take this opportunity to invite you to all in IAG National Conference in Varanasi on 15th to 17th of March. So it will be a great gathering there. So all the best to all of you, and we are looking forward to a great webinar today.
Thank you. Thank you, Dr. Ori. Our next guest of honor is Dr. Yatendra Verma, who's from Gwalior. Can I have the CV, please? Dr. Yatendra Verma is the director and embryologist, Dr. Verma Hospital and Fertility Center, past secretary of MP chapter and IFS. And he has trained in IVF ICSI cryopreservation. He's received a healthcare award in October 19 for excellent work in medical field. And he's doing FOGSI recognized training and center at his center for basic and advanced infertility management. Welcome, Dr. Yatendra. Do you want to share some insights?
Yeah, thank you for your kind words, Dr. Kar, and good evening, all friends. Wish you all very happy New Year 2024. And we are all running late. So I just want to communicate my best wishes for the coming ISAR and share the mic to Dr. Seema Pandey for further start the webinar.
Thank you. We have one more guest of honor, Dr. Sumita Prabhakar. Welcome to this webinar today, Dr. Sumita. Just display the CV, please. Yeah.
So,
she is President Uttarakhand ISAR, past President Dehradun OBG Society, member of RCOG, and member of FOGSI Oncology Committee, Urogynecology Pelvic Health Association, and advisor on Uttarakhand IFS chapter. She has founded IVF India Care, Laserwell, first laser and aesthetic clinic in North India. And she's trained more than 100 doctors. Her special interest is infertility and endoscopy, laser cosmetic gynecology, runs a FOGSI approved colposcopy training center, regularly presents paper in all the conferences, national and international. Welcome, Dr. Sumita. Please share a few words with us.
Thank you so much, ma'am. It's a great initiative, Dr. Seema. Congratulations to you. Very swiftly, you organized this, joint effort with the UP, MP, Uttarakhand, and Azamgarh Society. And my congratulations, and wishing everyone a happy new year. And again, I think we are running late. So I think we should just proceed with the academic session. And my best wishes, Dr. Seema and team, for this webinar. Thank you so much.
I would hand over now to Dr. Raj. Let's start.
Thank you so much, dear. Before we start the program, I would like to welcome our very own Dr. Sadhana Gupta. She is among the faculty. Ma'am has been Vice President from North Zone. She's been contesting also, and she is a mentor, teacher, and a kind of friend. Thanks a lot, ma'am, for this. I don't have your CV in my in front of me. So I welcome you wholeheartedly, ma'am. Thank you so much. Ma'am is co-chair, CEFOC, NCD committee, FOXY representative to CEFOC, Vice President FOXY, as I told you, 2016, FOXY past chairperson, Safe Motherhood Committee, and Dr. Mehru Dara Hansotia Award for Best Committee Activity she got. She was ICOG Governing Council member 2015 to 2021 and ISOPAP Executive Board member and Founder President Gorakhpur Chapter, corresponding national...
Seema, it's okay. Yes,
And
it's
ma'am
okay.
has got so many accolades and awards, and she's widely respected in this area. I welcome you, ma'am, and thank you, and would love to have few words from you, ma'am.
Thank you, Seema. It is always a great pleasure because you belong to Gorakhpur. Your alma mater is in Gorakhpur, and we live close by. And I'm really very much impressed with your journey, and especially what you have done in a very small place, very high quality RT services, very high quality endoscopy services, and your all name what the patient takes in a great respect. So this is something like everybody told about elections and everything, but we know as a doctor what really matters for us. And I heartily appreciate, congratulate Seema that your all going effort and in your all journey in the professional body as well as the professional field. I wish you all the best for your coming election. And we wish that you take the key positions in ISAR and take the academics and the clinical practice to higher level. And that will be, to me, it is always a proud day for a country when all country and the international scenario is this, that the people from a very small places are making medals, posts, and this is the time to change. So hearty congratulations. I'm really looking forward to your talk. You are a ardent academician, and that differentiation between obese and lean is very, very pertinent for our patient, because we really see a lot of lean PCOs which have a totally different management approach as compared to obese. So hearty congratulations. My all best wishes to your election and all the contestants who are there. I don't know how many contestants are there, but all the best wishes to everyone. And we look forward to listen to you.
Thank
And
you
my
very
all
much.
regards to all the chief guest of honor, especially Dr. Chandravati and all the friends who are having here. All I will not take name, but my all loving regards and my best wishes for the new year.
Thank you. Thank you so much, Sadhna ma'am. I would request Raj to start the talk and invite the chairpersons for the talk.
So good evening, everyone. Me again. In the presence of our star-studded galaxy of ISAR, let us now embark on our intellectual journey in the intriguing realm of lean versus obese PCO. How different is the approach? Where Dr. Seema Pandey is going to be guiding us and looking into the nuanced insights of this topic. And to chair this session, my first chairperson is our most respected Dr. Sadhna Gupta, madam. Seema has just had the privilege of introducing ma'am. I was hoping the privilege was going to be mine, but Seema stole it. And so, ma'am, hi, good evening, and most welcome. Our second chairperson for the evening is going to be my dear friend, Dr. Monica Jindal. Can I get somebody to display her CV, please? Monica's CV on the screen. So sorry, Monica used to be Jindal. She's now Singh. But I still have a number stored down as Jindal in my phone book. So as we know, Monica has been a star. She's been an academician all her life. It all started with her getting all those gold medals in her MBBS years that I would probably not be able to count on the fingers of my hands. She went on to obviously being an academician, being a professor. And from there on, she held the posts of Secretary of MP chapter of ISAR. She's been the Vice President of the Bhopal OBGY Society, VP of the Bhopal Menopause Society, Honorary Secretary of Bhopal OBGY Society, and so on and so forth. I mean, I
think
could
it's
just keep
okay.
reading
It's okay.
and it would not end.
It's okay, Rajlakshmi. That.
No, but there is
Dr.
one
Ranveer
thing that
Singh,
I do want to
Ron-
add.
These are lilies,
Monica has also got
You
us
take a
multiple
just say
awards at
you
international
know,
conferences by presenting her research, and that is something that I am proud of when it comes to Monica. So yeah, that is Monica for all of us. And our next chairperson is going to be Latika Agarwal. Can I have Dr. Agarwal's CV on? Is Latika around?
Trying to connect to her. Her phone is coming switched off this morning.
So we have another gold medalist who's going to be chairing SEMA's session. She has, to her credit, multiple research papers and textbook chapters, and she's successfully organized many conferences. She's had multiple awards, and she's been awarded the Woman of the Year 2 times, not once. And her expertise lies in IVF. And she is associated with our dear Jaideep and Narain, and she works with them. So basically, that is Latika. Now, as Latika is not there, may I please request Monica, can you please introduce Seema, our esteemed speaker for today, and also invite our subject experts who are going to be the experts for Seema's talk. Thank you.
Yeah, sure. Thank you, Dr. Rajlakshmi. That was a beautiful introduction, and we can't wait for Dr. Seema's talk now. After going through and meeting everyone from ISAR, the galaxy of dignitaries. And first of all, thank you, Dr. Seema, for having me chairperson of your talk, which is on a very contemporary and very much needed topic. In fact, just now, Dr. Rohan and myself, we were deciding upon a panel for AICOG, and I was going through Poseidon criteria and working on some slides. And there I came to know that very soon we will have the PCO phenotypes to plan our treatment. Very soon, a PCOS patient who walks into our chamber will not be treated according to the Rotterdam's criteria or according to the Androgenic Society of the World or any other classification. But you have to keep in mind the PCO A, B, C, and D phenotype in order to decide for her surgery, in order to decide for metformin, in order to decide for inositols, and even to decide her dose of stimulation. So that is Dr. Seema for you. Can I have a CV? I know everybody knows Seema, but I would...
Monica, please don't share my CV.
Let's
invite our experts.
I just wanted to talk a little bit about Dr. Seema. Dr. Seema is actually a friend, and we keep having our arguments in between, and we patch up very soon. But she is a person who sticks to you. She's a person who keeps her word, who is very passionate about friendship also and her work also. And along with academician, she is also a fun person. So you will find her, working very hard, studying very hard, and also enjoying life as it should be done. So welcome, Dr. Seema. Thanks for having me here, and we can't wait to listen to you now.
I would like to.
Do we have the subject expert?
Yeah, we have some subject experts for the talk, Dr. Madhuri Patil, whom we have introduced, Dr. Rajul Tyagi. If you have her CV, please display it quickly. And
welcome,
Dr. Kanchan
Madhuri
Sharma. And
I extend warm felicitation to Dr. Madhuri Patil. There could be no better person than her to, be an expert on PCOS. And is Dr. Rajul Tyagi here? Because I would love to introduce her if she is joined. She is a very eminent gynecologist of Lucknow and an ART specialist. We almost started practice together, and this is like the way her graph has grown, it's phenomenal. The amount of energy she has means I sometimes sleep in the middle of a conference. By the third or fourth lecture, I'm dozing off, but she's all alert on the first row. And she, can you imagine, she makes notes also. And she puts into practice what she learns. So she is an institute. She is an inspiration. She has got lovely, hardworking daughters who are gynecologists as well. And I know her since past 18 years. I'm totally a fan of Rajul ma'am. And there could be no better expert than her. This, I think there are two experts, Anuradha.
Yeah, Dr. Madhuri, and now the next expert is Dr. Kanchan Sharma.
Yes. In fact, Dr. Kanchan Sharma and I, we just had a talk this morning only. So can I just speak about Dr. Kanchan Sharma? She has
Yes,
been
please.
she
Yes,
has
please.
been in the limelight and the headlines because she is a person who has ventured into Foxy and into ISAR very strongly, very positively. And she's the person with the smile. Like I think smile is her identity and smile is her USP. And we all know and congratulate her for becoming chairperson-elect of the NCT committee of Foxy with a very good margin. She is also recipient of Foxy Achiever Award. She's just recently organized a very beautiful conference in Kanpur, which we enjoyed, NatCon. She's been awarded with so many awards and has been a keen organizer of academic events from national to international. We can see her quizzing, quiz master, and has held multiple executive posts in the societies of Kanpur. We welcome you, Dr. Kanchan Sharma, as an expert in this talk. Thank you.
So, should I start now?
Yes, Sunita, please go on. Yes, Seema, go ahead. Sorry.
So I am just trying to, and by the time I'm sharing my screen, I would just like to thank my seniors and friends from UP, MP and Uttarakhand chapter who did not take single minute in saying yes and permitted me to have this webinar. Thank you so much. I'm having some problem. My screen is looking small. Just hold on. Yes. Can you see my screen?
Yes, ma'am. Slideshow.
Yes, I am going to do it. So, respected seniors and dear friends, we are going to talk about lean versus obese PCOS. As our expert said, that this is the way we are going to talk about PCOS treatment, PCOS counseling, and everything. That is, how does this girl or lady look? As we all understand that polycystic ovarian syndrome is a polygenic, polyfactorial, systemic inflammatory autoimmune disorder with dysregulated steroid state, which manifests largely due to lifestyle errors. And it is the most common heterogeneous female disorder. Basically, polycystic ovarian syndrome is a metabolic disease with underlying ovarian defect, obesity, insulin resistance, and infertility, cardiovascular problems, and psychosocial issues are its comorbidity. So when we talk about lean and obese polycystic ovarian syndrome, sorry, my screen had I had lost it for a minute. So first of all, my sincere regards to my respected chairpersons and experts. And now I'm going to start the talk. Just pardon, because I was just lost in arranging my slides. So lean PCOS are those polycystic ovarian syndrome patients. You are looking at them, but they look just like any normal female, but they have come to you either with the irregular periods or most of the time either subfertility, miscarriage, or pimples. So they make this lean population makes less than 20% of PCOS population whose BMI is less or equal to 25 for international norms, 23 for our Indian females. Waist hip ratio is less than 0.8, and that's why they take longer to diagnose. On the other hand, any obese PCOS, which makes more than 80% of population, phenotype A and B, if we are talking about classic sisters, they come to this category whose BMI is more than 25, whose waist hip ratio is also more than 0.8. And these are the women who come to you with the concern of not able to lose weight, they're having subfertility, they're having sleep apnea, and other features of insulin resistance. So A lean PCOS patient can also come with polymenorrhagia. She's not, her period do start with medicine, stop with medicine. They might be having, as I said, acne, fertility, miscarriage. But the other group, along with these features, will also be having metabolic derangements like altered lipid profile status, GTT deranged, or frank NIDDM. I was reading by the age of 30, 60% of polycystic ovarian females, especially obese one, they land up either into deranged GTT or frank NIDDM. But both of these phenotypes, whether PCOS is lean or obese, there are certain things which are common, like insulin resistance is inherent to polycystic ovarian syndrome patients, irrespective of their weight. Hyperandrogenemia is pertinent to this PCOS, irrespective of their weight. Acanthosis nigricans, menstrual dysfunction is hirsutism. Endometrial hyperplasia, though it is more into obese group of the population, but even lean PCOS patient, they have almost equal incidence of having endometrial hyperplasia, and polycystic ovarian morphology is something which they share commonly. So if we look at the percentage wise thing, while 50% of lean PCOS will be presenting with frank signs of hyperandrogenemia, it would be 75% of obese PCOS. Menstrual dysfunction will be in 44% of lean PCOS, that would be around 80%, as I already mentioned, along with increased GD type 2 diabetes and GTT and relative. So obese individuals with polycystic ovarian syndrome suffer from more severe hormonal and metabolic derangements compared to their lean counterparts. But we have to remember all the features, especially the one I'm going to talk, that is insulin resistance. It is inherent in women with PCOS, and hyperinsulinemia ensues as a result. Lean women with PCOS have significantly greater insulin resistance compared with their BMI matched non-PCOS. If we talk about the prevalence, about 83% of lean PCOS and 93% of obese PCOS as per Diabetes Association and other international associations are having insulin resistance. So next time, if your lean PCOS, she is looking very pretty but not responding to your treatment for any cause, don't forget to add some insulin sensitizer to this patient. The reason for this insulin resistance is pancreatic beta cell function, which is greater in all PCOS women, and you have to remember it is more disturbed in obese because PCOS and obesity, they act synergistically and independently, resulting in insulin resistance. Researchers propose that insulin resistance needs to be ascertained at an early age. So when we had compared lean women with PCOS, hello, is there some problem?
I would request everyone to mute, please, except the speaker.
So sorry. So this, when these lean women were compared with the BMI matched healthy controls, there were certain features which were really disturbed, and it made them for us to investigate earlier for all these features to make their future life easier and better. That was lean PCOS also had significantly higher plasma insulin level, higher LDL and total cholesterol level, even higher hemoglobin levels. That is something specific to PCOS, and that is testosterone stimulated, along with raise GGT levels, and it is a good predictor for cardiovascular disease and death, which is higher in both lean and obese PCOS. Blood viscosity of these patients are also deranged and raised in both lean as well as the obese PCOS, which leads to increased risk of endothelial dysfunction, coronary artery calcification. There is elevated erythrocyte aggregation, and the weakened antioxidant defense system and erythrocyte deformability is something which makes these people prone to getting cardiovascular diseases, miscarriages, and bad oocyte quality. Now coming to these two hormones, adiponectin and ghrelin, these are being discussed a lot nowadays. So I just thought to introduce few lines about them. Adiponectin is secreted by adipocyte and is involved in lipid and glucose homeostasis, insulin sensitization, and possesses anti-diabetic property, while ghrelin is produced predominantly by neuroendocrine cells in GI tract, and this is thought to be involved in the regulation of energy homeostasis, glucose metabolism, and insulin secretion. The high level of adiponectin and ghrelin appears to be essential for glucose metabolism, and in obese women without PCOS, these levels are significantly reduced, as well as ghrelin level. So when I just summarize all these features in lean and obese PCOS, as I already told that insulin resistance is present in both. The percentage is lower in lean PCOS. Hyperinsulinemia is more pronounced in obese. Blood viscosity, increase hemoglobin, increase all these things, and comparable level of decreased adiponectin and decreased ghrelin level make them pro-inflammatory, and that's the reason, one of the reason why they are not able to lose weight as compared to their own counterparts who are not having polycystic ovarian syndrome. So obese PCOS are at greater risk of morbidity at a younger age than lean PCOS patient and need to be treated using more rigorous approach. Their psychological aspect is also different, as lean PCOS has lower resistance to stress, decreased adaptability because of higher ACTH and higher cortisol level, and while obese PCOS are at higher risk of psychological disorders, higher rate of anxiety, emotional distress, and higher depression, as we all understand that PCOS per se is a reason for anxiety and disorder, anxiety and depression, and it gets exaggerated by the various symptoms of polycystic ovarian syndrome like obesity, hirsutism, and other body features. So this was also calculated by different studies, and they found that it is like same. So when we talk about the differential diagnosis, when it comes to lean polycystic ovarian syndrome, most of the time it takes longer to diagnose them, and they are being confused with congenital adrenal hypoplasia, androgen secreting adrenal or ovarian tumor, Cushing syndrome, hyperprolactinemia, thyroid disorder, non-classical late onset CH, and medications that cause hyperandrogenemia. Coming to their control and management, as we all understand that lifestyle modification is first line of treatment for polycystic ovarian syndrome. Now, the question is, people will say, what about lean PCOS? Why do they need to go to lifestyle modification when they are not overweight? Let me tell you, friends, as they are having higher chances of more than 70% of these lean PCOS, they are having insulin resistance and hyperinsulinemia. Lifestyle modification is going to make their life better by decreasing the insulin resistance, strength exercises, gaining an ideal weight, and maintaining that weight and not gaining and being overweight is the aim which we give to lean PCOS by doing lifestyle modifications in terms of dietary intervention and regular physical activity and behavioral therapy. And it also ameliorates hyperandrogenism by indirectly decreasing the hyper-LH bound hyperandrogenemia. So these lean PCOS ladies, they are encouraged to consume vegetables and fruits to ensure they are having an adequate supply of various minerals, vitamins, and nutrients. At the same time, obese PCOS, as we all understand, even if they lose 5 to 10% of the body weight, their chances of ovulation increases by 40%. So does their chances of getting pregnant. Recent guidelines, they stopped talking about low carbohydrate diet, and they have been telling that diet should be balanced and low hypocaloric, not low carbohydrate. But recent studies have gone back to our previous understanding that if a polycystic ovarian syndrome patient, she wants to conceive, she has to be having low carbohydrate diet. It does not only increase clinical pregnancy rate, ovulation, menstrual regularity, SHBG, but it also decreases miscarriage rate, serum AMH, FAI, total T, and clinical signs of hyperandrogenemia. So when this meta-analysis was done, they found longer the patient had low carbohydrate diets, better were the effects. And these effects were, that means, associated with the treatment duration. So if you want your PCOS lady to conceive, ask her to be on low carbohydrate diet. Physical activity per se does not have much effect alone, but aerobic exercise had positive impact on body composition. And once this PCOS lady who is obese or overweight becomes pregnant, this body composition is going to help her and reduce her chances of getting so many complications like GDM, PIH, preterm deliveries, and everything. So coming to the drug therapy, as we all understand that these patients, both the groups are anovulatory most of the time, except for BCD. So if they are anovulatory, B and C, sorry. So if they are anovulatory, letrozole is drug of choice. If it fails, then for both second medical line of treatment is gonadotropin, and third is in vitro fertilization. This lifestyle modification for lean PCOS is maintained by high protein and roughage and anti-inflammatory diet and regular exercise to maintain the weight. And as per their symptoms, if they are having hirsutism, then we have to treat mechanically and by pharmacological treatment. So does menstrual dysfunction, acne. For infertility, we have to understand that drug of choice for lean PCOS is also letrozole. So is it is for obese polycystic ovarian syndrome. But these lean PCOS patients, before I come to that, the aim of giving any kind of ovulation is just to make monofollicular growth. And if you want a monofollicular ovulation induction in lean PCOS as well as obese PCOS, the first line treatment is letrozole. But as Dr. Monica was saying, in future, we are going to treat these patients as per phenotype. Here comes the role of using clomiphene citrate along with metformin, which can be given to obese PCOS whose BMI is more than 30, who are having features more suggestive of metabolic derangement than androgenemia. Please Please mute. While in lean PCOS, if letrozole alone is not working, we can add we can add insulin sensitizer, metformin, or inositol, and it was said that adding these adjuvants in lean PCOS, I mean insulin sensitizer, works better in lean PCOS than obese PCOS, and that is a fact. If you want multifollicular growth, if you have to meet the threshold as well as extend the window that you can do by extended letrozole protocol, letrozole step protocol, or letrozole CC plus gonadotropin protocol in these patients. So oral ovulagens of choice letrozole, clomiphene can be used, but most of the time it gives CC resistance and failure. So whenever you are planning to use clomiphene, please add metformin along with this. Third ovulation, metformin is not a treatment of choice alone in any of the group, whether it is lean or obese. So minimal starting dose should be chosen in lean PCOS, that is 2.5 milligram. Maximum dose in obese you can go per day is 7.5 milligram per day, and no letrozole resistance has been reported yet. Trigger to be given when follicle reaches more than 20 mm. And as I already told, if letrozole is not working alone, either add metformin or go for CC plus metformin in patients with BMI more than 30. If there is CC resistance and failure, first line is letrozole, but the best treatment for CC and resistance failure, obese or lean PCOS, is gonadotropin plus metformin plus minus intrauterine insemination. Intrauterine insemination is being used as these patients who are ovulating but not conceiving, whether they are lean PCOS or obese PCOS, it can be used in both, but we have to take care of the doses, as the chances of getting hyperstimulation are not that much with our letrozole, but chances of getting multi-fetal gestation is too much. So we have to avoid and go for the right dose. If that's not working, laparoscopic ovarian drilling is reserved for those patients who in lean PCOS who are very young, duration of marriage is less than 5 years, their BMI is less than 25, their LH is very high, and they are not ready to seek any treatment, but their AMH should be less than 8 nanogram per ml. And even hyperandrogenemia, testosterone level is very high. They are not ready at any cost to go for gonadotropin, either because of cost or distance or any reason. Those are the patients who can undergo laparoscopic ovarian drilling after being counseled properly, or peri-op, post-op complications like adhesions and decreased ovarian reserve. But you have also to make them understand that the effect of LOD does not remain beyond 6 months, and metformin plus letrozole or CC plus metformin or gonadotropin are equal or in fact superior to LOD in certain instances. So it has to be in very super selective patients where you can offer them this thing, laparoscopic ovarian drilling. When it comes to this COCs, when we were a student, our teachers used to prescribe 2 to 3 cycles of oral contraceptive pills before starting the ovulation induction. That seems to be a right choice for lean PCOS group of patients, where you can give 2 cycles of COCs, especially any 3rd or 4th generation, followed by ovulation induction with letrozole. These are the patients who are going to get benefited by myo-inositol, as it does not decrease the weight much and it is good in taste as well. And as I've already told you, metformin works better in lean PCOS. If your patient is obese, apart from lifestyle modification, which includes weight loss, You can use metformin, myoinositol, letrozole, all the combinations. And these are the patients where we should not be using COCs much. And one more thing that was uses of steroid or Dexona or betamethasone in patients along with ovulation induction. And the reason and concept behind using steroid with ovulation induction is to decrease the level of adrenal sources of steroid, so your ovulation induction agent works. So these are the various protocols which we use for lean and obese PCOS. And gonadotropin plus IUI works best for CC non-responders, and vitamin D support should always be given to all the patients, whether they are lean or they are obese PCOS, and along with calcium supplementation. As I told you that myoinositol is a boon, as it and it should be given in doses of 2 to 4 gram per day. It reduces LH, high C-reactive protein, androgen. It improves insulin tolerance as well. So it acts as a direct messenger of insulin signaling and improve the glucose uptake. L-carnitine is also a good choice for lean PCOS, and it should be used as an adjunctive therapy in the management of insulin resistance, especially, in obese PCOS who have PCOS. So if I try to conclude my talk, in obese PCOS, lifestyle modification, insulin sensitizer, plus metformin, letrozole, gonadotropin are the choices before embarking upon IVF. While in lean PCOS, you can do COC pre-treatment. You can give them dexamethasone starting from day 5 till day 14 of the cycle, letrozole, insulin sensitizer, and laparoscopic ovarian drilling in very super selective patients. When it comes to IVF-XC, we all know that antagonist protocol with agonist trigger and freeze all or segmentation of the cycle is the choice. Lean PCOS dose requirement is lower, as they have higher chances of getting hyperstimulated, while obese sisters like phenotype A and B, they act like resistant PCOS, and there the doses requirement is higher. And PPOS protocol is the new kid on the block, which has been really working excellently for these patients, as we have to go for assisted reproductive technique. It has been seen that lean PCOS, they behave better, they give better result than obese PCOS when we perform ART, be it in forms of their oocyte number, their formation of blastocysts, implantation rate, clinical pregnancy rate, and live birth rate. So, friends, whether you are getting lean PCOS or obese PCOS, you have to be sure that your lean PCOS is getting a variety of nutrients, minerals, and vitamins in their diet. And your obese or overweight one, though she is trying to lose the weight, but you have to make sure that her micro and macronutrients and mineral share is given equally importantly, and possibly that could improve her weight loss journey. And in addition, because lean patients with PCOS do not need to lose weight, they do not need to restrict their calorie intake, but low carbohydrate diet goes longer way if they are trying to get pregnant, especially if they are miscarrying. Complementary to the dietary and lifestyle changes, patients need to focus on supporting their body by promoting healthy hormonal balance, a healthy uterine lining, regular ovulation, estrogen metabolism improvement, and a healthy pregnancy. Thank you so much.
Thank you, Dr. Seema. Is Madhuri ma'am there for comments? Okay. Ma'am is there. Ma'am?
Yeah, it was an excellent talk. So I just wanted to mention that there's a newer parameter, the neck circumference, which has come apart from the waist circumference as well as the waist hip ratio. And they say that they've divided into 3 groups, that is less than 39 to 42 and more than 42 as high and low, intermediate and high risk for insulin resistance. And that also gives us a measure of obesity, and the positive predictive value with that is almost about 83%. And we also need to know that both the lean as well as the obese PCOS have abnormal cholesterol levels. And it's more so which is seen in phenotype A as compared to B and C, whereas in the lean PCOS, as well as in the obese PCOS, it's more in phenotype B as compared to A. So I think measuring lipid profile in all these PCOS patients is very, very important. And the mechanism of androgen excess in lean and obese PCOS is different. In the lean, basically, it's related to LH and growth hormone, which increase the IGF-1, and then it results in hyperandrogenemia. Whereas in the obese, it is basically increase in IGF and decrease in IGF-BP1, which then decreases the SHBG, and then that leads to hyperandrogenemia. And I think otherwise most of the things were covered. And I think if anything is there, I mean, people can ask me and I can always answer.
Dr. Seema, that was a beautiful talk, and yeah, that the concept of neck circumference sounds very interesting, and especially I think we will soon define the level at which the neck has to be measured, and we can easily inculcate. It's an area of the body which can be easily measured in OPD. The patient can do it herself, and that sounds very, very promising. I just wanted to mention about, I'm totally into this, so I'm just putting in a word for intermittent fasting. So this is something, I'm also a mild PCO probably. So, this is one measure which helped me a lot in reducing weight, which I had put on in perimenopausal years. So intermittent fasting, you don't have to scare the patient. This is the easiest way, which doesn't require any fancy exercise. Just, about 2 to 3 kilometers of walk per day or 5 days a week will do. The concept is that the patient need not be scared. She just has to be, emphasized with the fact that you don't have to eat dinner. I think dinner is one meal which you should miss, or if you want to eat dinner, just finish before 7. And a concept of just 12 hours of fasting. 12 hours means she does not have to take anything before 7. And the biggest thing which we have the Indians, we want is that morning cup of tea. So that cup of tea has to be replaced with either boiled water or some, green tea, or probably, some herbal tea, or, a black coffee will do. So as soon as your patient starts fasting from 12 hours to 14 hours, there is automatic fat burning, and it works. It's very easy to do, and the patient gets a sense of accomplishment, of power. So this lady starts getting confidence in herself, and she can do then better things. And of course, vitamin D, it cannot be overemphasized that everybody needs a little bit more sun than they are getting exposed to. And definitely vitamin D supplementation is the need of the day, and it's in my prescription most of the patients now. Thank you so much, Seema, for a lovely talk.
Yeah, so basically,
yeah.
Yes, ma'am. Yeah, so basically, again, one needs to know that there are several studies which have been conducted, and none of the studies have proven that reduction of weight is going to improve the live birth rates in the obese patients. So basically, what we have to tell them, because then they would respond properly, because there are other effects of obesity apart from the live birth rates, what we need to look at, because they can have effect on the endometrium, they can have effect on the oocytes as well as the embryo quality. And we know that they require more days of stimulation as well as increased dose. The other fact is that it's not only the obese that require lifestyle modification, it's also the lean which require, because these lean patients, though they are lean, they are sarcopenic, that is, they have visceral obesity
Yeah,
and
visceral
less
obesity.
of muscle mass. So
Yes,
they
ma'am.
require, they always require weight training, and
Yes.
probably yoga is going to help them. They might not require to decrease their weight, but they have to increase their muscle mass. So
Bas.
that's a very, very important concept. And in the Indian population, we need to say that below about 23 is overweight and about 25 is obese, according to the Asian standards. And there was a paper which was published in 2008 by the physicians of India in the journal, and they have said that about 23 is overweight and about 25 is obese. So we need to keep in mind that the criteria for obesity, according to the Western standards, does not work. And the effect on infertility because of obesity is not only related to the increased dose or the insulin resistance, but it is also related to its effect on the endometrium, which is there because of insulin resistance and hyperinsulinemia. And the other thing is leptin resistance, which is again very, very important. And we know that the hyperandrogenemia, which can affect the follicular levels of various hormones, and it has been seen that the HCG levels are lower in the follicular fluid in obese patients as compared to the lean patients, and they also therefore can affect the follicular genesis, and then it's also known that they can affect the oocyte as well as the embryo colony.
Thank you so much, dear Madhuri. I was not very sure what all to include in this talk and what to miss. So you have completed the spectrum. We just have to remember a lean one can go to obese and vice versa. And basic pathophysiology, the way and route is different, but ultimate result is the same. So we have to work accordingly. Now, Raj, please, and don't worry, we have increased the duration of this Zoom meeting. So our panelists will be getting equal chance, and we are not going to stop it at 8. We'll continue for an hour. Take care.
So after that lovely brainstorming talk and equally informative inputs from our subject experts, let us crack on with the next part of our academic session today. A lovely panel discussion on conception in PCO patients, what needs to be done differently. And for this, we are very privileged that we have a galaxy of panel. But before that, let me introduce our lovely subject experts. Dr. Sujata Kar. Can I have the CVs on the screen, please? Sujata's CV has already been read out, but let me just start by saying that we're really happy to have her here. The second subject expert that we will have for the panel is going to be Dr. Rakhi Singh. Rakhi, again, a very dear friend of mine. She has a profound understanding of the dynamics of reproductive health, and she has contributed a lot towards reproductive medicine and ISAR over the years. It is really my pleasure to have Rakhi here chair this panel now. And last but not the least, we have our lovely Priya Bhave, who is an academician. She's a researcher, and she has immense work on PCO. And these are going to be our three subject experts. May I request Rakhi Singh to introduce our moderators for the panel, please. Our moderators are going to be Anu and Dr. Aarti. So I'll request Rakhi Singh to introduce our moderators. I hand over to Rakhi, please.
Thank you, Raj. It is lovely to be on the webinar with all the star-studded webinar which Seema has incorporated and brought forward to all of us. And can we have the formal CVs for introduction? I think it should be auto mode. It should be played. Backend team, please. And we've got two lovely moderators for us today. Hello. Can we have the CVs, please?
Corona team, can you please put up the CVs of our moderators, please?
He is not ready to. Let me get it out.
It's displayed, ma'am. Rakhi, ma'am.
I was taking it out. We've got Dr. Aarti Luthra with us, another star from Dehradun, and she has got she's the immediate past president of Dehradun OB/GYN Society from 21 to 23, which is ongoing right now, and joint secretary of UPIAGE 21 to 23, UK coordinator for Foxy Endometriosis Committee, and founder chairperson for the Uttarakhand ISAR 18 to 22, and North Zone coordinator for the Foxy Medical Disorders Pregnancy Committee, and invited faculty and speaker at various nationals and international platforms. She's been the
we can quickly move to the panel. Thank you so much. It's always a pleasure seeing everyone.
And I would like to introduce the other moderator, who is Dr. Anuradha Kar, and with whom we've been hearing all this while. She's another big star in herself and humble. And Dr. Sujata, we all know she is director for the Nurture IVF Bangalore, currently practicing infertility and infertility related endoscopy at Bangalore, joint secretary of Karnataka chapter of ISAR, honorary treasurer and Karnataka chapter of ISAR 23 to 25, and MBBS from the prestigious King George Medical College, Lucknow, MD from Government Medical College, Srinagar, fellowship in reproductive medicine from Bangalore, and she's a good, lovely friend of mine, dear to my heart. Both the moderators are very close to me.
Thank you.
Over to you.
Thank you so much. Thank you, Rakhi, and thank you, UP ISAR, MP ISAR, and Azamgarh Society Uttarakhand ISAR. And what a beautiful collab effort put up by our own Dr. Seema Pandey. We start the panel. So I am going to invite our panelists, Dr. Randhir Singh, Dr. Vandana Bansal, Dr. Upendra Oli, Dr. Sangeeta Maheshwari, Dr. Akriti Gupta, Dr. Aradhana Gupta, Dr. Bharti Maheshwari, Dr. Shweta Kolja, Dr. Garima Sharma, Dr. Anchal Garg, Dr. Ekika Singh, and Dr. Diksha. Welcome all. So we will start our panel now.
Let's see who all are here.
So the topic for today's panel is conception in PCOS patients. What is to be done differently? And I also, we are co-moderating, me and Dr. Aarti. So Dr. Aarti is there, yeah. So this is the world of PCOS we have already heard from Dr. Seema. It is phenotypically evident in certain cases, in most of the cases on ultrasound, on hormones, and on laparoscopy, everywhere we see. So this is the world of PCOS. Now, I would like to ask Dr. Upendra Oli. Sir, are you there?
Yes, ma'am.
So the first question is for you. How PCOS women are different than normal women when it comes to infertility treatment?
Yes, madam. Very nice question you have asked. As compared to normal women, PCOS women required extra treatment for various disorders of polycystic ovarian syndrome, like menstrual irregularities, anovulation, oligovulation, hyperandrogenism causing hirsutism, alopecia, acne, acanthosis nigricans, and male type of baldness requires extra treatment for that. Patient of hyperinsulinemia due to insulin resistance required insulin sensitizers like metformin, minoxidil, anastatin, etc. These women require pre-treatment with OCP like cypertron, acetate, and ethylene estradiol in cases of hyperandrogenism. These women also have more chances to develop GDM and type 2 diabetes mellitus. For that, there is more chances of complicating during pregnancy and labor. These patients have metabolic syndrome causing obesity, BMI more than 25. Due to that, these patients require high dose of the gonadotropins. So they have more chances to develop ovarian hyperstimulation syndrome. During the stimulation, some patients have high yield of oocytes, create extra burden in IVF cases, require embryo freezing. For PCOS patients, sometimes have poor quality of oocytes. So there is more chances of implantation failure. Empty follicle syndrome, miscarriage rate is also very high, but sometimes chances of multiple pregnancy are there. Some women have a high LH level that is also responsible for resistance to ovulation induction and require higher oral ovulations. These patients also have more chances for hypothyroidism and hyperprolactinemia, require extra treatment for that. PCOS women have high risk of developing heart disease, hypertension, endometrial carcinoma, breast carcinoma, and due to hyperestrogenism, the PCOS patient also have anxiety disorder and depression due to negative body images. So these are the extra efforts we have to do for PCOS patients.
Thank you, Dr. Upendra. Dr. Shweta, you want to add something extra to this, what Sar has given us? Yeah, Dr. Shweta, are you there? Yeah.
Yeah. I think so. Kaika wants to say something.
Yeah, Dr.
Yeah.
Ekika, can you?
Hi, Dr. Anuradha. How are
Hi.
you? Looking very
Yeah.
pretty. And hi, Shweta, I love your specs. Sorry for, being just off the mark.
Dr. Ekika,
Yeah,
how
I
will
want to
you
just say
treat?
one thing.
Yeah.
I just want to say one thing. Sir has beautifully explained, I think, everything A to Z about the difference between between the normal female and a PCOS female. One thing which I really want to add, it's not only they who are affected, it is the fetus in womb once they conceive. If the metabolic syndrome has gone to a level that it is affecting the mother, it is going to affect the fetus also. And if it is a female fetus, she is also genetically going to have this problem for her. So it starts right in the womb. So probably it's not only between the normal female and a PCOS woman, it is even the fetus of the female which is affected. So that is the add-on which I really wanted to add when it comes to PCOS. And yes, when it is not controlled, so not only the woman, it is the fetus, if she conceives, that is also the one which is going to be affected. And it will get it right from the beginning, right from the time of organogenesis.
So, music, where it is coming? I don't know. Dr. Diksha, you have some more.
Yeah, I think the question was more pertaining to how these women are different than normal women when it comes to infertility treatment. So I just wanted to add is that these are the group of women who will be more obese, as we heard the earlier lecture. They are the ones who will have higher LH levels and higher insulin levels. So when we treat them, they will be having a wide spectrum. A lot of them will have a higher FSH threshold. And then when they respond, they have an explosive response. So they are more prone to hyperstimulation. And some of them, on the other hand, will have a higher FSH threshold and behave like poor responders. Also, these are the women who would also, when pregnant, face more issues of PIH and gestational diabetes and miscarriages and low birth weight babies.
And many of these women are very resistant to the ovarian inductions which we do. They are unresponsive, and we keep increasing the dosage of simple ovulagens like letrozole, and still we see that they are resistant to the treatment, and then we start adding other things and add-ons and gonadotropins, and that's the difference what we have. So Dr. Aarti, I would like you to take the next question.
Yeah. So this question, I was thinking, Dr. Anuradha, once we put the question, we can have the screen so that we can see all the panelists, because everyone is, eagerly waiting to add something. So, and then we can have a discussion like a round table discussion. So my question is to Dr. Sangeeta Maheshwari. She's a good friend. She's from Dehradun only. She's a practicing IVF specialist. That Dr. Sangeeta, what do you decide while choosing an ovulation? How do you look at the choice of drug, and what are the factors which you keep in mind while choosing an ovulation for a PCOS patient?
Good evening, ma'am, and thank you for the question. Ma'am, the most important point would be the metabolic parameters of the patient, her weight, duration of her infertility, and the severity of the metabolic syndrome that she's having. And most commonly these days we are offering as the primary ovulation letrozole only. And sometimes we need to add some gonadotropins. So
No, my
basically,
question is, like, you have started with letrozole. So will you right away jump on the gonadotropins, and what are your views about adding metformin, myoinositol, different drugs which can help in improving the outcome along with ovulation? And how many cycles would you try with an oral ovulation before switching over to the injectable ones?
Ma'am, first we are going to definitely give them all these adjuvants like myoinositol and metformin. Even for lean PCO patients, as ma'am had discussed in her talk, that we should add metformin also. And as per ASHRAE guidelines also, metformin should be added even for the lean PCO patients, because it improves their risk of getting into OHSS, and the quality of eggs improves. So definitely a pre-treatment with all these drugs is desired. And once we start letrozole, either we can go for a regular routine 5 days letrozole, or in some cases extended letrozole protocol can be tried, where we'll go up to 14 or 16 of follicle development with continuous letrozole use. And if
How do
she's not
you use a constant dose, Dr. Sangeeta? Or may I ask Dr. Garima, like, what is your experience if you're using an extended dose therapy with letrozole for induction of ovulation in PCOS? Do you use an increasing dose or the same dose for 10 days? And what is the number of days which you for which you continue the induction?
Thank you, ma'am, and thank you, Dr. Seema, for inviting me here. Ma'am, I want to add, before we step on to ovulation and the extended protocol of letrozole, an extreme important thing is patient counseling, that you have to counsel them that it might take a longer duration for them. So stop counting on to the ovulatory day, that the ovulation has to happen on day 14. Till the time there is a synchrony between an egg growth and an endometrium, she can even conceive on day 25 with this kind of a regime. So in extended dose protocol, automatically her cycle gets prolonged. And I, in my practice, usually continue with the same dosage for good 10 days without stepping up or down regulating, because there is no concept of changing. By the time you change, it takes up to about 72 hours, 3 to 4 days for a basal threshold to be maintained on a higher or a lower downgradation level. So it is a constant dosage for me for 10 days, along with the thorough counseling.
Dr. Madhuri has raised the hand. You have some.
I just wanted to say that metformin decreases the chance of OHSS only in a GnRH agonist cycle. It is of no use in an antagonist cycle. So this is the most important thing one must remember. It does not decrease the chance of OHSS in an antagonist cycle. The other thing on the extended letrozole and other therapies, it has been seen that even the new guidelines do not accept extended therapy. They have advised only 5 milligrams of 5 days of therapy. And if you look at the various Cochrane reviews, initially the Cochrane review said that we have to give metformin for a minimum period of 3 years in those patients who have a abnormal IGTT only, and this will probably improve the outcome. And this was in 2012. Then in 2014, they said that probably it reduces the risk of OHSS in patients with GnRH agonists. But the most recent Cochrane review, which was published in 2017, said that in a patient where gonadotrophins are used either in a non-ART cycle or an ART cycle, it does increase the chance of live birth rate. So you can see that the Cochrane review has given different views over the years, and this is depending on the various RCTs which were published over the years. So the evidence also had changed for using metformin. So the most, and still there is no evidence for using an extended letrozole or clomiphene citrate therapy, though there are certain papers which also used a combination of clomiphene and letrozole. But again, they found that the results with this combination were not good.
Thank you. Thank you, ma'am, for adding.
Ma'am, can I add something?
Yeah, sure, Dr. Ekika.
Thank you, ma'am. Ma'am, the first thing while choosing an Ovilugen, what do you look? Ma'am, when the patient comes to the OPD, there are 3 things which we look at, which really help us decide just by seeing and by a history, whether she is a bad PCOS, whether she, ma'am said no extended protocol, but I think many of the people practice extended protocol. So any patient who has a history that she bleeds only after withdrawal.
Yeah, but when we are talking in a panel like this, we have to talk only about evidence-based medicine. We cannot talk about each individual person is using. So that's a total your experience, and that is what you feel or everybody feels. But if you look at evidence-based medicine, it does not approve of an extended protocol.
Ma'am, I'm just saying what is that we look for. I look for, like, if the patient is having a withdrawal bleed, only after giving medicine, she doesn't bleed even after 2 months or 3 months of the cycle. She is obese. And on ultrasound, if you see the day 2 ultrasound, then you see that the stroma is very thick and high and the follicles are peripherally arranged. These are the patient who might require a higher dose for the Ovilugen to act, or maybe they are the one in which gonadotropin has to be used. So these are the basically phenotype A and B, which might not respond to the Ovilugen given for 5 days. And in these are the patient that during counseling also, that we tell, or we can tell that, yes, these are the patient who might require the gonadotropin dose for the follicle to come.
Yeah, but Dr. Ekika, we have to try the letrozole first. That's the
Yes, ma'am.
baseline choice, right? And then we,
but these are the patients in which it becomes difficult to, sometimes even get them ovulate. So this is what during the counseling, they're choosing an Ovilugen. That is what, while we're seeing the history and on the ultrasound basis also, one can really have an idea that, okay, this is a patient in which we might need some other things also besides giving a letrozole. That is what I would.
That is absolutely correct, because when you do TVS day 2 scan, you get a feeling. But first cycle, obviously, the patient has to be explained that we may not get good follicles, but still we want to see the response with the oral drug first, and then we may switch over to the injectable ones.
Yes.
So we move on to the second question, the other question now, the choice. What is your choice? Protocol of choice for a woman with BMI 27, duration of infertility 5 years, and predominant finding for this patient is hyperandrogenemia. So what will you give? Dr. Aanchal Garg, can you answer this?
Yes, ma'am. Thank you, ma'am. And thank you so much for having me here. Thank you, Seema, ma'am. Good evening, everyone. Ma'am, here I feel that the BMI is raised, and along with hyperandrogenemia. So first of all, along with the lifestyle modifications, I'll go for letrozole, as that is the drug of choice, and 2.51 BD can be given from day 3 to day 7 of the cycle for 5 days. And along with that, because of the hyperandrogenemia, I would like to add dexamethasone also at bedtime, 0.5 milligram from day 1 to day 10. And along with the letrozole, if we see that there is a little response, then we can add gonadotropins later on for this patient. in the dose of 75 to 150 HMG.
Say something? Yeah. So basically, I think the treatment will depend upon the age of the patient. So if the patient is less than 25 to 28 years, then we can wait for about 3 months after advising her lifestyle modification. Second, it will also depend on whether she's taken any treatment in the past or not. If she's taken treatment in the past, then probably with oral ovulagens, we can then probably go straight to gonadotropins. But if she has not taken treatment, we should, as she said, we should first go with oral ovulagens. And basically, for hyperandrogenemia, only if the DHEA is high, your dexamethasone is going to help. Does not help in patients who have increased ASD or total testosterone levels or the free androgen index. So today, the best choice of what is done when you are evaluating a PCOS woman is doing a free androgen index by doing a total testosterone and SHBG levels, which will give us the free androgen index. So that's the most important thing what we need to keep in mind. And before we go, because she's married for 5 years, nothing is mentioned about the menstrual cycles, whether they're regular or not regular. But it's important at this stage to evaluate her tubes before we go in for ovulation induction and any other form of treatment.
So any patient who comes, we have to evaluate other parameters for her, including a semen analysis, because our treatment, she's been infertile for 5 years. So we have to do a semen analysis and then start this ovulation induction. Of course, if she has gone to multiple people, we'll check those records. Accordingly, it will give us a insight in how we are going to respond, how we are going to treat her. Dr. Aarti?
Yeah, we are going to have our next question, and I'm going to take opinion of Dr. Aradhana Gupta, who is a practicing IVF consultant in Bhopal. Dr. Aradhana, I want to take your opinion for your protocol of choice for a lean PCOS patient who has an AMH of 7.5 nanogram per ml. Her periods are delayed up to 45 to 50 days. And she has been trying naturally. And this is for the first time she has walked to your clinic. And when you do her AMH levels, these are 7.5. Semen report is normal. Both tubes are normal. And this patient is only 26 years old.
Thank you, Aarti, and thank you, Seema, Dr. Seema, for inviting me for this lovely, webinar. And I'm really amazed to see the good questions. So this is a very important patient because we encounter these lean PCO patients, and sometimes we fail to identify that these are PCO because they are so fit and everything is fine with them, unless there is hyperandrogenism with them. So if there is no features of biochemical or clinical features of hyperandrogenism, and she is only a lean patient with an ovulatory cycle with a high AMH 7.5, then my choice of ovulation would be the letrozole. And because she is lean PCO, so I would start with a lower dose, that is 2.5 milligram daily. I would start with the oral thing, and of course, I would advise for not to gain weight and not to have a healthy lifestyle, and with a food which is less in carbohydrate. These are all things will be taken into the part. And then I will start with the oral ovulation with a little lower dose, 2.5 milligram with the letrozole. If she responds well, these patients are important because they may pass into the hyperstimulation. You have to keep a close watch on them. So more frequent ultrasound may be required with them, and they might have a premature LS surge. So these are few things you have to keep in the mind while starting the stimulation to such patients.
Dr. Akriti, would you like to add something? Like what else do you advise to these patients with high AMH? And, another question is, like this patient was told by some other practitioner, first we'll normalize your AMH and then we would like to induce you. What is your perspective on this?
Thank you, Aarti ma'am, and thank you, Seema ma'am, for having me in this wonderful webinar. So, as ma'am, Aradhana ma'am already said that since she's a young woman, she's lean, so we'll start with a smaller dose of Ovilogen 2.5 and subsequently watch the cycle. And we can also add as myocytols because that's a supplement for this patient. Along with that, yes, lifestyle, as ma'am said, resistance training, strength training, so that increase the lean muscle and tell her that you should not put on weight. And moreover, that ma'am, as you said, that AMH is high and somebody has suggested that you would normalize the AMH. This is a very commonly asked question by very, these young couples who come to us and they say, I did AMH 1 year back, then I did 2 years back, and still it is this much. It was higher, now it is coming down, or they have this question. So at the most, first we have to counsel them. Our aim is not to change your AMH or, to lower your AMH. Our aim is to make you ovulate. So, and get you pregnant. It's not, our aim is nothing to do with your AMH, that we're not aiming to decrease it. So this is a counseling thing which I tell my patients because this is very commonly asked. So my AMH last time was this much.
Yeah.
So the counseling starts with it.
Absolutely. Thank you. I want Dr. Madhuri ma'am's opinion. Ma'am, as evidence says that myo-inositol doesn't help in getting better results in reproductive treatment. And I have practically stopped writing it for all my patients, except very young PCOS who have badly irregular cycles. But we want your expert opinion on the same, ma'am.
I have never used it in my life.
Yeah, same here. I mean, I'm using it.
I practice evidence-based medicine, so I would not. And one has to look at any infertility patient is spending such a lot on the treatment. Look at the cost of myo-inositol. It is very, very expensive.
Yeah, it's very good. It's very expensive.
So I think we should, and all the adjuvants what you use, one must think twice before we use the adjuvants because you are adding cost to their treatment. And we don't look at that aspect of the patient. And I think that leads, spending so much money leads to more stress. And we know, as you know, that stress can decrease again the chances of conception. So I think this is a very, very important thing. So basically, when a patient is thin, I feel, and if she is not responded to the oral Ovilogens, then only one should go for gonadotropins. And then in this, probably we should use a chronic low dose protocol because we know that patients who have a high AMH are poor responders because this high AMH prevents the recruitment of the small antral follicles, and it also has its action wherein it prevents the action of the FSH on the granulosa cells, and it also decreases the cytochrome P450 activity. And therefore, they are poor responders. And as soon as you increase the dose, basically, it's just like walking on a tightrope and they'll suddenly explode, have multifollicular development.
It's a double-edged sword.
Patient, the doctor and the patient both have to be patient. And you need to probably tell the patient that we're going to use a chronic low-dose protocol, and it might even take 20 days, 25 days for your follicle to grow if we require a monofollicular growth.
Thank you, ma'am. We can move on to the next question, Dr.
Can we just add one thing?
Yeah, sure, Seema.
Yeah, sorry.
Dr. Seema, you are muted.
Dr. Seema,
You're muted.
You're muted. Please unmute you.
I'm feeling out of the action. I just wanted to add each nanogram of this AMH per ml is going to decrease her chances to get a successful pregnancy. It is a very high risk factor for this patient to undergo recurrent pregnancy loss as well. So we have to take that also whenever we are looking at higher AMH patient. She is a bomb. She either can hyper respond or she doesn't respond. So we have to be very careful about that.
Dr. Seema, I just wanted to ask you and Madhuri ma'am, any role of supplementation of vitamin D3 in such patients and even metformin?
No, so basically vitamin D3, you do the levels. If they are normal, I don't think they require supplementation. But if they are abnormal, probably you need to supplement them. And if the patient has taken repeated treatments and she has ovulated and yet not conceived, one addition could be a CoQ because it will help in improving the mitochondrial function. Because it is known that in patients with PCOS and those who are poor responders have an abnormal mitochondrial function. So that is one additional thing which one can do if she's had repeated failed she's failed to conceive despite having ovulatory cycles. And metformin basically will depend. If you're using gonadotropins, as I said even earlier, that probably metformin does have a role, though the patient may not have an impaired glucose tolerance. But if you're using oral ovulagens, it's not really going to help in improving the live birth rate.
Okay. So we move on to the next question. So let's check now. A patient of PCOS with normal BMI is going for, now we want to do an ovulation induction. What are the things you will be doing beforehand, before inducing a patient? She's coming for the first time. She's a young patient, but she's normal BMI. But she has biochemical features and polycystic ovaries. What will you do? Yeah, the question goes to Dr. Shweta Kolja.
Hi.
What
Hello.
else you'll do investigations for her?
Thank you, Dr. Anuradha, for this question. Thank you, Dr. Seema, for having me here. And Madhuri ma'am is here, so I am little, very alert with my answers because I have been with her for months together. So I know. Okay. So the thing which we will, for this patient is regular routine investigations, thyroid, prolactin, though she's a regularly menstruating woman, is it? So by the guidelines, we need not check the thyroid prolactin, but in regular practice, we do check her thyroid prolactin, first thing. Second thing is semen analysis. And then we'll give her ovulagens and see whether she ovulates or not. So we are just talking about regular female who looks like PCOD, and we are seeing her whether she ovulates with regular dose of ovulagens or not. And if the husband is having normal semen analysis, then whether she conceives or not. Okay. Now, second point comes of the tubal evaluation, whether we need to do it or not. So if you go by the RCOG guidelines, in PCOD per se, they say it is an anovulatory dysfunction, isn't it? So there is not a mandatory HSG that needs to be done. But if you are suspecting because of any history of some abdominal surgery or long-lasting infertility, more than 3 years of infertility, I mean, if you're suspecting, then you can do that tubal evaluation and then go for the cycle. So basic investigations and then basic ovulagens and then see.
What is your basic dose you'll give this patient?
No,
Which dose you'll start?
Anuradha, one more thing.
Yeah.
One has to do an OGTT as well as a lipid profile in all these patients. And if you look at the diagnostic algorithm, which is given by the international guidelines, if clinically the patient has irregular cycles and she has signs either biochemical or clinical of hirsutism, you don't require an ultrasound for diagnosis. If she does not have, then probably you can add ultrasound for diagnosis. But one has to look at the BMI, the OGTT, as well as the lipid profile, which is important. Apart from the routine investigations, what you're going to do, that is the semen analysis, the thyroid, because now according to the newer guidelines, they say that thyroid can affect, and therefore one has to evaluate the thyroid. And here, doing the TPO antibodies is also very, very important, because if you look at the correlation between hypothyroid, because hypothyroidism is one of the differential diagnoses of PCOS, and it has to be excluded before we label the patient as PCOS, because there are several factors which result in a PCOS like morphology in a patient with hypothyroidism. This is very important. And especially presence of antithyroid antibodies is important, because if they are present and the TSH is normal, still a small dose of thyroxine is required to improve the outcome of pregnancy. It might not affect the fertility treatment, but it will definitely improve the outcome of pregnancy.
Dr. Garima, I would like to ask you how many cycles of ovulation induction you would give this patient, a young patient, not done any ovulation earlier. How many cycles you'll do before you go to the next level?
Yes,
oral ovulation. I'm talking about oral ovulation. And she is responding. She's responding. You give one cycle letter, she's respond, not conceive. How many times, how many months you'll give her?
So basically, we are saying that she is showing a kind of an ovulation, what we call it as, she's been ovulating in all these cycles. And for her, you counsel her that if she's a young patient, not married with a short duration of infertility and ovulating, I think 6 cycles is a good enough. But if she's on a higher range of the age, long-standing infertility with other parameters being normal, you can cut short it to 4 cycles of ovulation induction, provided he's ovulating in all the cycles.
My question is, will you go for 6 cycles without testing the tubes? That's
No,
my
ma'am,
question.
we already
Yeah.
discussed. I thought that, so basic evaluations have all to be done. Dr. Shweta Kaul did mention about the tubal evaluation as one of her preliminary investigations. So it is only, as I said, all other parameters normal, ovulating in all cycles, young patient, short duration of infertility, 6 cycles. Any other compounding factor, you have to cut down and investigate.
So Dr. Aarti, you can take the next question.
Yeah. Here, I would just like to add that if a patient has a thin endometrium, because many a times if a patient does not respond to letrozole as an oral ovulation, we do use clomiphene citrate. And the new guidelines, the 2023 guidelines have said that using clomiphene plus metformin gives better results as compared to clomiphene alone. And with this, if you have a thin endometrium, the other option is that one could use tamoxifen along with metformin, because one of the indications for using tamoxifen is the thin endometrium, because with tamoxifen, you have a good thickness of the endometrium.
Yeah, thank you, ma'am. Dr. Aarti?
So this patient has come to Dr. Aanchal now. She has tried with oral ovulation and she has not responded. And we have tried for 4 cycles for this lady who's a young lady. So now what are the other options which we can offer to her?
Ma'am, first of all, we will look into the causes of the non-response, and we like to know her age, then her BMI, then the status of the androgens, and we can add after knowing this, we can add like metformin for this patient along with letrozole, and if that also does not work, then we can go for gonadotropins.
Which protocol would you like to use, and which is your choice of gonadotropin for this patient?
I would like to use the HMG for as the gonadotropin, and the step-up protocol for these patients, starting with 75 international units of HMG.
Do you like to use highly purified HMG? Do you find any difference in using highly purified HMG and regular HMG?
Not much difference, ma'am. Mostly I have been using the normal HMG instead of the highly purified for the PCO patients.
Okay. May I invite Dr. Garima to add her opinion?
Ma'am, in these given situations, I think considering the BMI is also very important to discuss.
Same patient with BMI of 27. Yeah.
Yeah. So if she's a higher, because if you're using a typically chronic low dose step up protocol, in her given situation, as Dr. Aanchal also said, 75 may be the right choice. And the second thing which I want to add on is sometimes there is a cohort of patients who are going to be your hyperandrogenic, hyperelect secretors, might not respond to your HMG. That is a small subset of population wherein you might need an FSH instead of HMG if you do not see any response on a chronic low dose step up protocol with HMG.
Okay. Lot of times we can start with 37.5 also if we use a multi-dose vial, and then we can see, because these lean patients, otherwise PCOS, sometimes it's a boom and they get into hyperstimulation.
She was obese, BMI 27.
Yeah.
BMI 27.
Yes.
BMI 27, but still we have to be careful in using the HMG or FSH dose in these patients.
In this case, ma'am, Dr. Aarti, ma'am, in this case, where the BMI is 27, in that case, if like what Garima said, in few cases where we can use recombinant FHS, that if I have to start, that we can start with 37.5 and then go ahead up.
Yeah.
Instead of if I'm not planning to give HMG and I'm planning to give recombinant, then 37.5, even in this patient, we can use.
HMG also can be used in 37.5. You have multi-dose vials.
Yeah.
You can start at 27. But I think the dose of your gonadotropins will depend upon the age of the patient, the aim, and the antral follicular count, which has then to be amended for the BMI of the patient. So basically, it will depend on these factors. So you need to look at the age as the age. Apart from that, the antral follicular count and AMH values are very important when you start your gonadotropin dose.
Absolutely. Thank you.
So
we'll go on to the next question.
Before Anu, I
yeah.
just interrupt one?
Yeah. Dr. Seema, you are muted. You're muted.
This question was very important. CC non-responders. These are two categories. I'm just summarizing it for general public who's looking at our webinar. So for CC non-responders, we have to divide either as per hyperandrogenemia versus obese PCOS, or we have to divide into CC resistance and CC failure. In CC failure patients or letrozole failure patient, first choice is adding metformin or insulin sensitizer. If it is not working alone and patient is only failure, CC failure or letrozole failure, we can also add IUI as an adjuvant for 2 to 3 cycles. And if that's not going, best cycle is going to be, as you have been discussing, is gonadotropin plus IUI. LOD in very selected cases, phenotype A and B, as Dr. Madhuri said, that CC plus metformin, as Cochrane meta-analysis has also reviewed, that adding metformin is giving better results in patients whose BMI is more than 30. So that would be one thing. And whenever you are adding metformin, that should be at least 2 months before when you are planning the next ovulation induction for these patients. And in resistance cases, you can go directly to gonadotropin because they are not able to meet the threshold with that particular drug. So that's what I just wanted to summarize before you go to the next case. And ultimately, if they don't respond, then IVF is the choice.
No, and in certain cases wherein you had resistance, one could also suppress the LH levels in the previous cycle by giving either progesterone or estrogens for about 8 to 10 days so that they don't affect the response to that. And then in case of failure, if you have not done the investigations, one should basically expand the diagnostic evaluation, what has to be done before starting the gonadotropins.
Thank you, Dr. Seema. So my next question is to Dr. Vandana Bansal. Is she there? She's not there. Dr. Bharati Maheshwari, are you there? Dr. Sangeeta Maheshwari?
Yes, she's there. She's there.
Dr. Sangeeta, this question is to you. A patient, 25-year-old, married for 3 years, had 4 cycles of ovulation induction with letrozole, but she's still anovulatory. What would you do? She's not ready for IVF.
Since she's not next, ma'am, since she is not responding with letrozole, we have to add some form of gonadotropin because we have already tried for 4 cycles and it's 3 years of infertility. So adding gonadotropins at this stage is justified, along with lifestyle modification if she has not been doing that. Since she's not ready for IVF, we may try 2-3 cycles of gonadotropin induction along with the IUI if she's ready for that.
But I think one can use clomiphene citrate with metformin if she's not. Yeah, if she's not responded to letrozole, and only if she does not respond to clomiphene citrate with metformin, then probably we need to go for gonadotropin therapy. And here you have to use a chronic low dose protocol because she's not ready for IVF. Because in case you have a multifollicular development and you want to convert the cycle into an IVF cycle as she's not ready, you're wasting that much of gonadotropin dose that is there. And one more thing is, whenever you're using gonadotropin, I think IUI is the best option. Because if you look at the pregnancy rates of gonadotropin with timed intercourse, which is same, it is about 8%, as it is with oral ovulations. But if they go for an IUI, the chances of conception is almost about 15 to 18 or 20%. So this has to be explained to the patient that if you go for timed dose with gonadotropin, your chances of conception are much less. And so it's better that they go for IUI if you are using gonadotropins.
Yeah, Madhuri ma'am, thank you so much. This question was put for this only, that if we know the drug of choice is letrozole, but we should not hesitate in using clomiphene also for certain cases if they do not respond to one drug. You cannot straight away jump to bigger things. So thank you so much. Dr. Aarti, next question.
Dr. Rakhi, I just wanted to interrupt. Dr. Rakhi, don't you think this patient is looks like an ideal candidate for LOD as well? The reason why she's not ready for IVF was put that she is a 25-year-old married for 3 years. If her BMI is not more than 25, can she be taken for LOD as well?
I still beg to differ, Seema, because she has just tried with letrozole. So, because if she doesn't have any associated tubal pathology or history of intervention leading to tubal block, because we have not given her good induction. So, if she's not keen for anything, which is IVF or extensive, we should give her a fair trial of gonadotropin induction. What does Dr. Madhuri has to say in this?
Yes,
LOD clearly out of vogue, and even according to the recent 2023 guidelines, they say that laparoscopic ovarian drilling should not be done. Gonadotropin is a second choice of treatment. But in case you're doing endoscopy for some other reason and you find that she has polycystic ovaries, then one can probably go for doing a laparoscopic ovarian drilling. But as far as possible, one should avoid laparoscopic.
Yes, thank you, ma'am. That was the reason why I did raise this question, because we want to put it categorically that please don't take this patient for LOD as a next step.
Your questions are very interesting, Seema.
Dr. Aarti.
Yes.
Next one.
Yeah. So this question goes to Dr. Shweta, and I know she'll be very, very clear on her opinion about luteal phase support in all PCOS patients or PCOS patients on oral ovulation or gonadotropins. What is your way of managing them post ovulation?
Yes, ma'am. So the thing is, if they were on oral ovulations, if the gonadotropins were given, then definitely luteal phase support needs to be given. Okay, and that mostly we give vaginal 200 milligram BD. So this one also I want to convey, because most of the gynecologists I've seen, they prefer to give orally, but vaginally the absorption is best. So micronized progesterone 200 milligram BD vaginally is the progesterone of choice for those PCOS who were on oral ovulations plus gonadotropins. Okay. Then as far as only oral ovulations are concerned, we do give them also luteal phase support in the form of oral dydrogesterone, 10 mg BD. So it depends on what was the ovulation thing which was given, ovulation agent.
Which is your, which is your drug of choice for luteal phase support? Because now for one group you have mentioned dydrogesterone, and for another group you have mentioned progesterone, micronized progesterone vaginal. So may I ask Dr. Aradhana, do you differ with your choice of progesterone support in these patients?
Yeah, Aarti. So vaginal micronized progesterone is my first choice for such patients. Unless a patient is having some, discharge issue or some itching or something like that, then only I go for the oral, this dydrogesterone only. And this is a costly, and for me, I think the patient pocket should be seen when you are choosing a simple, IUI or something like that. So that should not be very costly. If you have alternative, better alternative, and vaginal micronized progesterone, we all know they reach to the uterus directly and very fast.
Bioavailability is better.
So bioavailability is also better, and they are time tested. So this is really important. And
Madhuri ma'am wants to add something.
So basically, your dose of your vaginal progesterone depends upon the BMI of the patient. So if the BMI is very high, the dose of 200 milligram twice a day is really not going to be helpful. So this patient is going to require a higher dose. And one cannot say that only vaginal progesterone is time tested. You have Lotus 1 and 2 trials where they have used dydrogesterone even in IVF patients. In the first, they've used compared dydrogesterone in the dose of 10 ml, even in IVF patients. The Lotus trial was done in IVF patients where they had given dydrogesterone in the dose of 10 milligram 3 times a day. And in Lotus 1, it was compared with vaginal micronized progesterone. And they found that there was no difference in the live birth rates. In Lotus 2 trial, they have compared dydrogesterone with the vaginal gel, which was 80%, which was used once a day. And they again found that there was no difference. So one cannot say that only vaginal progesterone is time tested and dydrogesterone is not time tested. So that is totally wrong. So if the patient doesn't want to use vaginal, one can still use dydrogesterone. Only thing is when, especially in IVF patients now where we are using personalized luteal phase support, where we do the progesterone levels on the day of your embryo transfer. If you're giving oral dydrogesterone, the levels may not be same as when you're using vaginal progesterone because dydrogesterone cannot be measured as pure progesterone, which we measure in the blood. So it's going to be a totally different scene at all. So doing a individualized luteal phase support when you're using oral dydrogesterone doesn't make sense because the levels are not going to be reflected in the blood. It will be reflected only if you're using intramuscular or you're using vaginal progesterone.
Dr. Aarti, Dr. Anuradha, Rakhi, and Dr. Madhuri and Dr. Kanchan, here I am just saying something else. I am saying that every PCOS patient who is undergoing ovulation induction, especially with letrozole, needs luteal phase support. So I just want the input about that.
Ma'am, one thing I wanted to say, I mean, it is misinterpreted when I said that when they are taking only oral ovulagens, I give them oral dydrogesterone. And when we are giving gonadotropins, then mostly we are doing IUI along with it. So it is oral plus vaginal. That's all I wanted to say.
So these patients, they are having problem in
No,
their
why should you give oral
progesterone.
plus vaginal? It's not required basically. Either you give oral or you give vaginal. When you're even using the gonadotropins, you don't require giving a combination of oral and vaginal. And basically, if you look at the evidence which has been published, when you're using oral ovulagens, basically you don't require to give luteal phase support because why do we give luteal phase support? We know that the luteal phase is basically dependent on the LH levels. So when you're using gonadotropins, there is a feedback, there is a positive feedback, and therefore there is decrease in the LH levels, and therefore you require luteal phase support when you're using gonadotropins. But when you're using oral ovulagens, your LH levels are going to be normal, and therefore, if you look at the evidence, what they say that you don't require luteal phase support. But many of us do use luteal phase support given in oral ovulagens, but this is empirical. That's what I want to convey.
Dr. Madhuri, my question was that these PCOS patients, they have different mechanism and versatility of progesterone secretion in their luteal phase that also leads to implantation failure and miscarriages. And that's one reason and one school of thought why every PCOS is supposed to get luteal phase support. And according to some study that was
it's not there in the guidelines, Seema.
Yes, it's not in the guideline.
No, there
we are
will be
just
one occasional paper which has said that. But as I said, that most of us do use because there's no, the LH is quite high in patients with PCOS. But now basically, and that's why many a times I said probably we need to give oral contraceptive to lower this. But the new concept has come, and there is a lot of evidence that says that this LH, which is high in the women who have PCOS, is a chronic LH which is high. And that really is not going to hamper or result in a premature increase in the progesterone level. So why do we want the LH to be low? That is because you don't want to have a premature elevation of progesterone in the follicular phase, which is going to affect the endometrial receptivity. So that's one of the reasons. But if you look at, there are very few papers which say that you really require luteal phase support when you're giving oral ovulagens. But as I said, most of us use because we are really scared and we want the patient to conceive, and we use luteal phase support even with oral ovulations. But this is empirical. That's what I just want to convey.
So yes, evidence-based for gonadotropin only cycle, it is, the evidence is there. There are a lot of evidence for that you have to give luteal phase support. So we move on.
The same meta-analysis has concluded that luteal phase support even with oral ovulation is beneficial, especially if you are doing ovulation cycle with IUI or without IUI.
Yeah, so basically,
subgroup analysis.
Come only from an RCT, Seema. So if this is just a paper which has been published where they said that probably they've given and they have got, they say that it is required. Just one paper doesn't create an evidence. Though I'm saying most of us use it.
Yes.
But if you look at the evidence, just one paper, only if it is an RCT, and it has to be a crossover RCT, wherein in one cycle they have used luteal phase support and the patient has not, they've not used, and then the second cycle they've used and the patient has conceived, and it has to be a crossover RCT. Then only we can say that the evidence is there.
Okay. So the take-home message on this is that oral ovulations in PCOS patients, if you have used, luteal phase support is not mandatory, but we anyways give, right? Because we feel that it may help. But when we give gonadotropins, yes, you have to give luteal phase support. We're moving on now. A PCOS patient we have tried everything on her, 4 to 6 cycles of ovulations with gonadotropin, with IUI, everything has failed. Now we want to take her up for IVF. Dr. Ekika, this question is for you. Are you still there? She's not there. Dr. Diksha, are you there?
She's there.
Ekika is there.
Yes.
Ekika, okay, you can.
Sorry, actually, there's a lot of internet problems, so it's going
Dr.
in.
Ekika, you have a PCOS patient who has undergone everything, IUI, OI, everything, and everything has failed. Now, our next step is definitely IVF. So how will you do that IVF for this PCOS patient, keeping in view that PCOS patients are very, very much like they are sitting bombs? There is a low response on one side, and there is an hyper response on another side. So what protocol how will you do this IVF?
I mean, before embarking them on an IVF cycle, first of all is the counseling part, which will definitely go, and they should be properly explained the protocol which we are going to use we'll try our best that she doesn't land up in ovarian hyperstimulation syndrome, but yes, there are always the chances. So probably for her, the best protocol which we would select is antagonist protocol. And then I don't know, Madhuri madam will tell how the experience or maybe what is right. But then yes, the progesterone only, PPOS also protocol, that is also there, which can be used for an IVF stimulation in these cases of PCOS patient. So a freeze-all protocol, which can be done with the antagonist cycle or with the PPOS cycle, which can be taken for these patients, which we would like to do. So in antagonist protocol, depending upon her day 2 scan, her BMI and her AMH and rest of the thing, a dosage will be decided, probably maybe starting from recombinant follicle 150, 225, or maybe in some cases, which is bad PCOS, because of higher BMI, might have to start with 300 also. But if taking them along with the PPOS cycle or an antagonist cycle, chances of OHSS are low. They are not completely abolished. They are low. Stimulation should be with the agonist only, and then the freeze-all policy. That is the key which should be done for these.
So basically, like if you look at the new guidelines, what they say is that one cannot recommend an antagonist protocol or agonist protocol for improving the live birth rate. But they recommend using an antagonist protocol for its safety's sake, because we have an option of doing DNRH agonist trigger. But if you have stimulated the patient that have only about 8 to 10 follicles, then you can still give HCG trigger and you can do a fresh embryo transfer. But it's always important that it's better that you do a single embryo transfer in these patients. But if you have done and you find that the E2 is high, you have large number of follicles, then it's best that you do a freeze-all cycle. But in the beginning only, if she's in the past, she's had history of OHSS and you have decided that you don't want to do a fresh embryo transfer, then a PPOS protocol can be used. But if you're going to give an option of a fresh cycle, then I think one should not use a PPOS protocol. In my patients, I never always freeze all in all PCOS patients, and I've had pregnancies, and I always stimulate them less. And what I aim at is only 8 to 10 follicles. And therefore, I don't think in the last many years I've ever had a patient with OHSS. Even if I've done fresh embryo transfer.
Dr. Diksha, one question to you based on this is, supposing you have given 5 days of 150 or 225, whatever base dose you start, and you don't see the follicles growing after 5 days, the 5th day scan, what we all do. How are you going to proceed? What will you do with the dosage? Dr. Diksha, are you there? If you're not there, Dr. Shweta, what will you do? 5 days you've given, say, 150 or 175 daily or 225, whatever, depending on you. And in 5 days you do scan and nothing has grown. It's very small, same state it is. What will you do? Will you increase the dose? Will you continue the same dose? Or what will you?
In IVF, we are taking the patient for IVF, no?
Yeah. This patient, IVF patient.
I do increase the dose. I do stepwise increase the dose, and then I have taken to quite high doses, and days of stimulations are also like 15 to 18 days, and then finally we could take those 17 mm follicles, and we have done the pickup and frozen them. So with freeze-all cycle, I think so we have a lot of liberty of increasing the dose and going on for long days of stimulation also. Madhuri, madam.
Anuradha ma'am, if I could
might add HMG. No, instead of FSH, I might add LH either, or I will go to the HMG. Just
ma'am, I would beg to differ a little over here.
I think on day 4 in a PCOS patient, it's best to do a E2 level. Look at her E2 levels. If they're low, you wait for another 2 days, and then on day 7, you need to look to see whether a dominant follicle has developed or not. If you have a follicle which is 10 millimeters, then probably you can continue with the same dose. But when you do a scan again on day 8 or 9 and you find that the follicle is slowly growing, then it is best to add LH. You can reduce the dose of FSH. If you want to give the same dose, you can reduce the dose of FSH and add LH activity, because it is known that in many patients, LH activity is required. Though the LH is high in these PCOS patients, this is basically an inactive form of LH, and this addition of LH activity helps in the growth of follicle.
Doctor, my question was that only, that in 5 days, will you increase or you'll wait for 7 days? So probably we should wait for 7 days, do the 7th day scan. If it's the same thing, then we, add an LH or increase the dose later on. Now, my question...
And in these cases, Dr. Anuradha, if we are starting antagonist also, this has to be delayed. Generally, we know that protocol is 5, 10, 7, so it has to be delayed. Yes, flexible protocol till the time we see a growth of a follicle.
Yeah. Therefore, that's why doing a day 4 E2 level of the stimulation
will help you.
Important. Because if at that stage you find that the E2 is already crossed 300, then it's best even to start your LH, your antagonist earlier, if you're planning to do a fresh embryo transfer. If you're not planning to do a fresh embryo transfer, you can start your antagonist at any time. So basically, my starting of antagonist, because I prefer doing a fresh cycle, because one does not look at the epigenetic changes which happen because of freezing and thawing. So that's a very important thing. And you have not monitored your patients. You just look at the live birth rate. You have not monitored the patients once they're born and long-term effects, because it has been seen that freezing and thawing, wherein you take the embryos to -197 and again thaw them, can result in epigenetic changes, which can result in late several diseases in the children.
Dr. Aradhana, do you start
So,
only
I know,
FSH in the first few days, or do you start with HMG or cycles in PCOS? Just
Dr.
last.
Anuradha, just
Yeah.
one question from Dr. Madhuri. Yeah. So I agree, Dr. Madhuri, you are also starting an early antagonist. So as far as my understanding goes, early start of antagonist in a PCOS cycle, contrary to our belief, is better approach, as it not only gives you better clinical pregnancy and live birth rate, it also decreases the dose. So don't go on the size of the follicles if they have not attained, as Dr. Madhuri said,
No,
the E2
because see,
level.
if you
And
have
if
a
you cannot,
you have a multifollicular development. So because of the multifollicular
yes,
development, your E2 levels are always
that's
high.
E2.
So if you're planning to do a fresh
Exactly.
transfer, you have to start your antagonist early. And I
Yeah,
prefer
in that
the
case.
E2 level on day 4. If I find the E2 level is already crossed 300, then I would start my antagonist at that point of time. But if your E2
So
level is
that's
low,
what
you
I'm
can still
saying.
wait.
That's what I'm saying. But if you cannot do an E2 level and you are seeing multifollicular growth, even if it hasn't crossed 10, early start of antagonist is better in PCOS patients.
In that case, if you're planning to do a fresh transfer, that is what.
Irrespective of
Madam
that.
told me. Yeah. Okay. Okay.
Even endometrial lining can give the clue of estrogen levels.
Yeah,
Yeah,
Dr.
that is
Aradhana,
anti-latent
do you start straight away HMG stimulation, or do you give FSH and then add LH or HMG? Hello.
I'll start with a recombinant FSH in such patients because the
Yeah, tell
dose
me.
titration is easier. There's it's easy for the if you want to step up later, or because there's always you have to step up with a smaller doses. So the recombinant FSH is my choice. Now we have multi-dose vial also for the such purpose. So it's not that costly, which were previously with the pen we used to use. So this is my first choice, and I add LH only when I find that the response is not up to the mark.
Dr. Madhuri, what is your take on it? Do you start straight away with
Yeah,
FSH
in some patients, like if I've had a patient wherein I've given FSH and I've found that the follicular genesis was poor, and when I've added HMG, then it has improved. So if this patient fails to conceive in a previous cycle, then I would probably start her on HMG, because I would have already given her gonadotropins when I was doing a non-ART cycle, and I know what her response is. So depending on that, I would decide whether I would give HMG, because if you look at the evidence, it really does not make a difference whether you give rec FSH, you give urinary FSH, you give ultra pure FSH or HMG to the patient, as long as you have properly titrated your dose. It is not going to affect the results.
Thank you. Thank you, everyone. Dr. Aarti, next question.
Dr. Aarti had to leave. She had one emergency.
Okay, I'll take the next question. Now, it's regarding trigger. We all know this, but let's discuss this since we are discussing IVF. In antagonist protocol, the patient E2 level is 3,300 picogram per ml. LH is 0.5 MIU per ml. What will be your trigger of choice? This question is for Anchal Garg. Okay.
So,
If
ma'am,
Anchal, are you there? Yeah.
Yes, ma'am.
What trigger
In the
you'll give?
So here the estradiol level is very high, but here the LH level is also very low. So I would like to give her triptorelin 0.2 milligram, and along with that I'll give her HCG also, and then I'll go for a freeze all protocol.
Right.
Okay. So you are saying that you will give a dual trigger. Dr. Sadhna, will you give a dual trigger? Each panelist I'm going to ask. Dr. Upendra, will you give a dual trigger?
Better we go for agonist trigger and freeze all.
Dr. Sangeeta?
Or if you want to fresh transfer, then we can give dual trigger.
Okay, Dr. Sangeeta, what's your take? Will you give in this patient dual trigger or only
Dual trigger.
agonist?
Because it would be risky to give her only agonist. Her LH level is too low. And if 3300 E2 is not that high, that she cannot tolerate 2000 units of HCG. So I would go for dual trigger.
Dr. Shweta, will you give dual trigger or you'll give...
I won't be in the situation because I don't check LH. I check at the most E2 and I'll give straight away. In fact, I don't check that also most of the times. I'll give agonist for sure and freeze all. I want a good night's sleep.
But your agonist trigger will not act when the LH levels are low. So that's the important thing. So every patient of IVF, on day 2, you have to do your E2 and progesterone level because your E2 has to be less than 50 picograms and your progesterone has to be less than 0.8 nanograms per ml. And it's most important that you need to do your E2 and P4 levels on the day of your trigger. But if you find this is a patient of PCOS, so having a low LH level really will not be there. But if you've seen failures in the previous cycle wherein you're having a low follicular output ratio, then doing an LH level is very, very important, because if you have a very low LH level, then you're not going to get mature oocytes, and therefore if you're giving an agonist trigger, it's best to do after 12 hours. You need to do the LH and the progesterone level, because your LH level has to rise and your progesterone level also has to rise. So if these levels are not risen, then it's better that you repeat an HCG trigger patients. Otherwise, you're going to have empty follicular syndrome.
Yeah, this is that.
Ma'am,
That's
what's
why
the
this
LH
question.
level you expect after 12 hours? I mean, is it, ma'am, 12 international unit? I mean, the LH level after 12 hours. Is it more than 9 or more than 12?
The LH level.
LH level after 12 hours. Ma'am, in this case, this is what even I would have thought of doing.
It has to be more than 12.
More than 12. That's what I was thinking in this case, giving a trigger, then seeing at 12 hours, if it is more than 12, we are sure that we'll get good follicles.
But in this patient, you should give HCG trigger itself.
Yes,
Madam, I'm here. I have a question.
Thank you, Dr. Madhuri. Thank you, Dr. Madhuri. This was the main essence of this question. This LH level matters. Your agonist trigger will not work.
Not work. You have to give HCG here. That
Ma'am,
was this was a bit
can I
of trick
ask you-
question.
Can I ask you one question over here?
Levels for all your patients, first cycle. I'm just asking for all your.
Yeah, I mean.
All patients, day 2,
proven
P4 are very important, because your success rate is going to depend on that. And on the day of your trigger, one has to do E2 and progesterone level, because your progesterone levels will tell you whether you can do your embryo transfer or not, because if you have a rise in the progesterone level in the late follicular phase, it's going to be affected. So the cutoff levels for the progesterone levels are different in a poor responder, in a normal responder, and in a high responder. So in a poor responder, the progesterone level should not be more than 0.8 to 1 nanogram. In a normal responder, the cutoff level is 1.25 to 1.5. Whereas in a patient who is PCOS or a hyper responder, the cutoff of progesterone level is 2 to 2.25. So if you have anything more than this, depending upon the response, then probably you should not do a fresh embryo transfer. You should freeze all the embryos and do it in a subsequent cycle. And therefore, doing a progesterone level and knowing what type of a responder she is very important. And LH levels are especially important to know whether you need to give where you're planning to give a agonist trigger, you have to do your LH levels. If you're planning to give a HCG trigger, it really does not make a difference whether you do your LH levels or not. But if you're planning to do give an antagonist trigger, you have to do your LH levels. And after 12 hours, you have to do your LH and progesterone levels.
Ma'am, I had 2 quick questions on this only, the low LH levels. My first question was that instead of repeating the LH levels at 12 hours, do these patients respond well to increased dosage of GnRH agonist as the primary trigger?
No.
And my
No.
second,
No.
And my second,
it is required.
No.
And my second question was that when you give the HCG after 12 hours of evaluation, your pickup scheduling is 24 hours or 36 hours from the
It
HCG?
has to be 36 hours because your GnRH agonist trigger has not acted.
Garima, then why will you wait for 12 hours? That's the reason why
No,
we are
I wanted to
doing
know that
LH.
do we have any particular range of LH? We know that if it is less than 12, you have to give an HCG.
Yes,
But somewhere, is it any borderline 10 LH that you might have to shift your window of trigger earlier, pick up earlier? That is what my question was.
No.
Okay.
There's no need to do your trigger earlier.
Okay.
Okay, so last question of the day. It's regarding PPOS protocol for PCOS patient. What is your take on it? Let's start one by one. Dr. Sangeeta, what's your take on it? Do you use this protocol? How do you do it? Please.
I use it specifically for the donors. And
Okay.
for patients of severe PCO, when I have decided that she's going to go for Freezol, then I might choose it because of the cost factor.
Okay. Dr. Akriti Gupta, what's your take on PPOS protocol? Do you use it?
And ma'am, I use this mostly in the donors, not using for patients who are coming for routine self-IVF cycles in the OPT. Preferably
Dr.
going with
Aradhana?
antags.
Dr. Aradhana, do you use it?
Yeah, in the donor and for the fertility preservation, we can also use it. And sometimes I use in the patients of adenomyosis, where I want to do a segmentation just because of this adenomyosis. Or there is if some like a big endometrioma, then I do this stimulation first, freeze the embryo, then remove the endometrioma if I feel it might hamper the pregnancy or implantation, then I transfer the embryo. So these are the three categories where I use. Or if some patient who had previously shown hyperstimulation, in next cycle, I might go for this PPOS protocol. Then it is like, the cost cutting.
Okay, Dr. Shweta,
I do
PPOS protocol.
protocols, only anti-protocol.
You don't do PPOS?
No, not at all.
Not at all. Dr. Garima, do you do PPOS?
Donor cycles, madam.
Donor. Anchal, do you do PPOS?
Ma'am,
For
in some
PCOS, for donor, most of the people do. For PPOS.
Ma'am,
PCOS, sorry. PCOS.
Anuradha, can I add a word about PPOS?
Yes.
I just did a perfection series on PCO, and the inference we got from multiple data and studies was that PPOS substantially increased the gonadotropin consumption. So much so that whatever cost cutting you achieve by antagonist is completely overruled by the extra 25 to 35% of gonadotropins you consume. So unless if you're really fond of doing PPOS and you feel that antag is a big burden, you do PPOS. Otherwise, the cost cutting factor doesn't work at all.
Dr.
That's
Monica,
why PPOS is not becoming, that's why PPOS is not becoming so popular.
Dr. Monica, do you do this or you do your standard antag?
I don't do.
You do
I don't
antag.
do PPOS. No.
Monica, I am
Dr.
doing
Seema.
lot of PPOS cycle, and more I am doing, more I am feeling that especially PCOS patients of mine and poor responders, they are responding better with my PPOS protocol than they are responding.
And Dr. Monica, I wanted to ask you one thing, this substantial
I
cost.
do freeze all.
Yes.
I do freeze all. I don't do
The
full
most
cycles.
important thing is if
Deepika is also doing lot of
Yes.
PPOS.
Yes,
I think.
yeah, I'm doing a lot of
So
PPOs
I
for donor and for
so very happy with PPOs. I don't know what does future holds, but especially for my hyper responders, endometriosis patients, and I'm telling you, poor responders, simultaneously
even
antagonist and PPOS cycles are
better
for
we can
same
use better
indication.
I totally
PPOS
disagree.
are
For poor responders,
showing
you should
better
not
control.
do. No, you should not do a PPOS protocol because as far as possible, one should do a fresh embryo transfer in patients who are poor responders. Because usually these patients have low ovarian reserve, and usually if you look at the egg and embryo quality, basically it's not all that good. So, I think your freezing and thawing is going to result in more problems to this patient. And if the patient is going to conceive, and there are many who also go for double stimulation where they're using the PPOS protocol, where they do the first pickup and again they will do the second pickup. So when the patient is going to conceive in the first pickup itself, whatever chances are there, I don't think we should go for double stimulation.
Ma'am, there are a lot of patients
I
in which
don't
you have
do
to
double
you are doing PGTA, ma'am, 38, 39 years of patient.
Yeah, but then
If you really want to
if
go
you
for
look at the
PGTA,
literature, what they've shown that PGTA should be done only in good responders or patients. It should not
no,
be
no,
done
not
in
poor
good
responder. I'm
responders.
talking about the age, ma'am. It's the
Madhuri,
age. I mean, if a patient is 38, 39, 40, they are going for their self-fix, then they can be taken on PPOS protocol so that they can do their PGTA and then transfer.
Evidence says that it should not be done. If you look at the evidence for PGTA, they said that it is basically done in good prognosis patient and not in poor prognosis patient. Because anyway, there is a chance of having they're having
I started
the
this
cell mass may be
protocol
normal, so the outer cell mass may be abnormal. So you're going to discard that
Madhuri,
embryo. So whatever chance she's having of getting a pregnancy with her own embryos is going to be lost, and therefore PGTA should not be done in poor responders because
yes, agreed.
yes. No, because there is a lot of mosaicism.
Madhuri, I started
There is
PPOS.
a
Yes,
self-correction
I
also.
started PPOS for poor patients as a cheaper protocol. And later on, I realized that the same patient, when I was of same opinion, they should not be given PPOS, they should be given antagonists. But these patients, I was just wanted to cut the cost. And I did, and I retrospectively analyzed my own data. And I found that the pregnancy rate was at par, even better, though my number is very small. And that's how I decided pursuing those patients who cannot afford I'm doing them for 50-60,000 off the record, I'm telling. So I'm using PPOS, and that is giving very good result to those patients. I don't do it by choice, it is by cost cutting. And for PCOS patient, I can pay, and they are behaving better with PPOS.
No. If you look at the evidence, it is said that a GnRH agonist protocol is much better in patients with poor response, especially those with low ovarian reserve. I'll tell you why. Because the resultant more synchronous
We'll
development.
create our own evidence, Madhuri.
Yeah, tell me.
We'll
Sankara et al. And then
we'll
another
create a lot of data and your supervision.
compared agonist and antagonist. So agonists have better pregnancy rates.
Yes, that is
What is
definite.
the final
Even
verdict?
with
What is the
PCOS,
final verdict
even
on
in
PPOS,
PCOS, agonist protocol again is
No,
back
because
and
it
saying it
does
gives
not
better.
better synchronization of the follicles. Because your intermenstrual rise in FSH does not happen. In patients who have a low ovarian reserve, there's always an increase in the intermenstrual FSH levels, and therefore you have an asynchronous development of follicles. So to prevent asynchronous it is best that they say, therefore the results are much better with agonists rather than antagonists, and the dose which is required is not much, because anyway it is going to, and it is said that you should not use more than 300 even in a poor responder. Whatever you get, because if you use even more than that much, you're not going to have more yield. So at the most, you can use 300 or at the most 375. So otherwise, I don't think it is this thing.
Dr. Ekika, how much, ma'am, how much extra gonadotropins are used? How
Yes,
many
ma'am,
extra
that-
days?
Yes,
Yeah,
ma'am, that
let's
is what I wanted.
calculate.
Yes,
No,
and that is what I
because one is used, I use only 3, maximum dose what I use is 300. I don't use anything more than that. I prefer using HMG in a patient who is as a patient with low ovarian reserve and poor responder. Because if you look at the evidence that says that HMG gives better results in that group. If you look at the Poseidon group, adding LH in all the 4 groups has given better results with LH activity, where they use a combination of REC-FSH and REC-LH, but you can also use HMG and it gives a better results. So basically, if you don't want to use a agonist protocol, you have to give either estrogen or progesterone only for 8 to 10 days. If you give for a longer time, If you give OCPs, again, it is going to affect your results because it can affect the egg quality. So you give either, if you want to use an antagonist protocol and to have a synchronous development, you give estrogen and progesterone for 8 to 10 days, not more than that. And then once a patient gets her menstrual cycle, you can use an antagonist protocol. But if you have not used anything in the previous cycle, then I think agonist cycle gives better results. And there were quite a number of papers which have been published which said that in poor responders, probably agonist protocol is much better, though antagonist protocol is going to reduce the amount of gonadotropins that is required. But then we have to also consider the cost of the antagonists because they are much more expensive as compared to the agonists.
I think we have reached the end of this seminar, and thank you so much till we meet again. And Dr. Arshi, are you there? Okay, we all are going for ISAR elections. Ab mudde ki baat kare. Dr. Ekika, Dr. Monica,
Anu,
everyone
yeah.
is going, and Dr. Seema is going for
Anu,
librarian.
sorry.
I will invite you for vote of
No,
thanks.
no. मेरे को वो नहीं कहना है. मैं कह रही हूँ कि before we wind up, I would like each panelist to introduce themselves and whatever they want to convey to the to our lovely audience. Please feel
Okay,
free, and then I'll do.
Seema, I think we'll display their, some of them we didn't display the CVs. Is Corona people are there? Are Corona remedies people there? Can you display our panelist slides, please?
Stop sharing the screen.
Yeah, I'll stop it now.
And start with your own.
I have one suggestion to you. You should have a facility where your audience can ask questions. So that
That's
would
what
be more interactive. They can probably put it in the chat box, and whoever is monitoring your system of your webinars can put it in the chat box over here, and whoever is the expert can answer. So that will make your webinars more meaningful than having questions only from
We would like to have Dr. Randir's CV first. Go according to the flow.
Dr. Randir is not here, Monica.
Yeah,
No, he
yeah, I'm here. I have come.
Are
Seema,
nahi,
I
we
have
will.
come. At the last minute, I have come to vote you.
Hi, Arshi.
My
Whether
vote is the first.
we are following protocol, whether the person is there or not, we are going to display the CV. Okay, start.
Yeah.
So Dr. Randir Singh,
Yeah.
he's
Yeah.
an
See,
sir, you only introduce yourself. Please
So
talk
no,
about yourself.
I just introduced myself.
Person and he is always available.
Yes, sir. Yes, Satendra Verma, sir. Actually, I was some family problem was there for my brother, so I was doing PET scan and all. So I'm now free on the drive. So my one-way message is that I was the organizing chairperson of last ISAR, and I was the chairperson of my MP chapter, and I'm a ASHA certified embryologist, and I'm a director and president Bhopal branch Nursing Home Association, and I'm a state ART board member also. So my thing is that the voting of the ISAR should be as maximum as we did for Sunita Tendulkar Madam Foxy elections. It was 70%. So ISAR elections are not more than 50% in the last years. So we should motivate everybody to choose their best one. We'll not ask that you vote me or you, but we have to increase the voting percentages. That's all.
You're in there. Next. प्लीज आप लोग लाइन से अपने आप चालू हो जाओ, सबको एक बार
मैम मेरे को एक्चुअली एक
खत्म
इमरजेंसी
हो
है.
जाएगी.
There is one emergency. I really have to go down. So probably even if you display side or no, I just wanted to say thank you for inviting me for such a wonderful webinar. Thank you, Madhuri ma'am. There is always a lot to learn from you. Thank you, Dr. Seema. I love your enthusiasm. And I really want to tell everyone that she is one of the, not only one of the, she's the ideal candidate for the librarian. As I have seen her, I have grown with her. I know her. She has really a good academic intel in her mind, and she loves to teach. So a librarian, you think that she should be knowledgeable. She is one of them. So for her, I want to say that. And for me, I just want to say that just like Dr. Seema, I'm also working in a small rural area. We both try to bring the advanced things which are there in the metros to the people out here so that they also can get benefit from the modern things which are happening. And just like Dr. Randir, yes, let work for ISAR together and let's see that, I mean, everything good reach to the patient, which is the ideal goal in an optimum evidence-based way, and we support each other. Thank you, madam. Having said that, I'm also one of the candidates for the managing committee ISAR, and I would really love to take a leave because my one patient is waiting in emergency. And thank you, everyone. And thank you, Madhuri ma'am. It's always
Ekika, for
good to learn from
joining
you.
and endorsing me. Thanks, darling. Thank you.
Thank you, ma'am. Thank you. Thank you.
नेक्स्ट लिंक बंद हो जाएगी, फिर कुछ नहीं कर पाएंगे. डॉक्टर मोनिका, डॉक्टर श्वेता, डॉक्टर अनुराधा, डॉक्टर आराधना, डॉक्टर गरिमा, डॉक्टर आंचल, these are our candidates for managing committee along with Dr. Randhir and Dr. Monica and Dr. Ekika. Yes. So please vote for these people, I am saying, because they are not speaking, and this
And
this link is going to expire. And thank
I
you,
would
Arshit,
like to
for
say
joining.
a few words. Please vote for Dr. Seema.
So
Because
let
she is the anchor of all these webinars. She has done such a hard work. She took every call whenever we tried to connect with her, and she responded so nicely. She is such a nice, lady, and with such a warm-hearted and with a brilliance. So I am really, I appeal that please vote for her. And we are so many people who are contesting for the managing committee is our member. So that is fine, but Dr. Seema deserves most. And
I make a vote appeal for my dear friend Dr. Seema. I don't think
Anuradha is also contesting.
Dr. Seema. No, I am contesting managing committee. I displayed my slide. I want that Dr. Seema kindly vote for her, give her a chance. I think she is the best candidate we have with regards to academics, with regards to as a good human being. So approachable she is. And she's a very loyal ISARian. She's been very loyal to ISAR.
Very
now.
And I also want to add for Seema ma'am 2 things. She has truly mentored me like a bacha, which she always quotes. And the bestest quality is to bring everyone together in a platform and move together is something which is lacking, but is one great virtue of hers to bring us all on this platform, and truly an ISARian.
And
So
I second
last-
the vote of Aradhana and Anuradha for Seema. I second the name of Dr. Seema Pandey, like Aradhana and Anuradha, for
Thank
the
you, sir.
librarian, and
So-
she really deserves for this post.
I think Seema is a winner already, but still, because there are strong contestants, Seema has to keep working hard for the rest of the 18 days till the goal is reached, right, Seema?
So yeah,
We are
you're
with you
right,
from
Dr.
24/7.
you have to
So
say something.
now,
Congratulating all the
as we are
contestants
going
in
to
advance.
Dr. Seema, you are still looking so fresh. I mean, I wonder really, how could you manage that?
So
Madam,
now,
I
as we all are winding up and the link will be closed, so this is my last word that please support for the post of librarian to my dear Seema Pandey, who is a great leader, a great mentor, and a great teacher also. So everybody will agree to it. And secondly, the second great leader who we have seen the power is Dr. Anuradha Khai. I am supporting. I'm asking you all to please give your valuable support to Dr. Anuradha Khar for member managing committee. They both are gem of the person, and rest all my friends like Dr. Monica Jindal, Monica Singh. Previously she was Jindal. So Dr. Shweta Kaul, everybody is a gem, and I support everybody, and I ask everybody to please think sensibly and make them all a winner. Thank you so much.
Thanks a lot to
Thank
Dr.
you.
Madhuri ma'am. Whenever I
Dr.
listen to
Seema.
her, I always get mesmerized. And
Madam,
she is like a gem person. I don't know. I mean, she is like a treasure to be kept, and she is
Where is Madhuri? Is she there?
she is like
Dr. Seema, can you please
full of
give vote of
wisdom,
thanks
full of
now,
wisdom.
please?
Raj is saying something.
Dr. Seema
Yeah.
has to give vote of thanks. Please thank before we exit.
Dr.
I just
Raj
like
is
to make
saying
the
something.
announcement that Dr. Seema Pandey will give the vote of thanks. It is already done.
All have given the vote of thanks to Dr. Seema.
Before I start that thanking, first of all, I would like to thank a dearest friend, a mentor who has been throughout this whole webinar with us, gave her sincere inputs, Dr. Madhuri Patil. We all love you. You are an amazing human being. Apart from being an academician, everybody knows whenever you ask for anything, she is always ready, and you made our day, and it was a great learning. And thank you, Dr. First of all, I would like to thank my chairpersons from UP, Dr. Neelam Mori, from MP, Dr. Yatin Singh Verma, and from Uttarakhand, Dr. Sumita Prabhakar, and their lovely secretaries, Dr. Latika, who could not make it from my chapter, Dr. Monica Singh, who is here till now, and Dr. Akriti Gupta, our youngest leader. Thank you, darlings. Thank you so much for giving your support. And our all our panelists, Dr. Oli, thank you, sir, for just giving your valuable time. Dr. Aradhana, Dr. Garima, Dr. Shweta, Dr. Randhir, Dr. Aanchal, our, I cannot see, Akriti, Sangeeta, and any panelist I have left? No. And our experts, Dr. Kanchan Sharma, Dr. Rakhi Singh, Dr. Sujata Kar, and Priya Bhave could not make it, it seems. All of you were wonderful. If there was any mistake that was not done knowingly, please forgive it, and let's move together and make this world a better place. Thank you, Corona Solaris, for providing this platform, which went without any hitch till now. This is the first platform where we didn't have to fight for the time extension. Ki badhao, hamara panel chhoot raha hai. Everybody had, and thank you all our dignitaries, esteemed chief guests, guests of honor, experts, chairpersons, for making this meet special. Till we meet again, good evening is converting into good night now. We have changed to good night, Isarians. We'll see you all soon. We'll meet again. Thank you. Bye-bye.
Thank you so much.
Thank you.
And thank you,
Bye, Dr.
Mehul.
Ma'am.
Thank you, Mehul, Vipin, and Manish. And my back-end support, Mr. Anup Pandey.
Thank you so much, Dr. Seema and Corona
Thank you.
and
Good night.
everyone. And
Again,
I
requesting
really,
everybody, and requesting everybody, please ask your friends, please ask your friends to vote maximum.
I
Please
really,
do
I
vote,
really,
do vote. And
Dr.
thank you,
Seema.
Arshi, for joining. And I forgot the most important person, my master
Raj.
ceremony, my best friend Raj Lakshmi Walavalkar, who has started this webinar on a correct pitch and took it to the heights. Thank you, darling. Thank you so much. Where are you?
I really don't feel
She
any
had left.
competition because all are known people and all are friends. I really don't feel. And may the best people win.
Yes.
Thank you so much.
Thank you, Dr. Nada, for taking this panel to such a nice, smooth way, and the questions were really good. Dr. Seema, I think you have created all the questions. They were really very good questions. Very
Yeah.
practical approach and very nicely taken forward by Dr. Anuradha. Thank you very much. Thanks all.
जो छूट गया वो
Thanks all. My
जो छूट
वो
गया है,
मुझे पूछना भी है
सीमा
डॉक्टर
सीमा
माधुरी मैम ने और ज्यादा अपने को इंक्विजिटिव कर दिया टू लर्न यू नो एवरी टाइम आई
मेरे
लिसन टू हर ना
क्वेश्चंस के जो मतलब थे वो कुछ मतलब और भी थे.
कहीं और चले गए
अगली बार डिस्कस करें.
We are blessed to have Dr. Madhuri
we are
in
waiting for the
Bangalore.
next panel.
Yes.
Thank you
We
so
are waiting
much.
for the next panel.
Yeah, sure.
Definitely.
और
Okay, should we
जो
leave?
जो
And
छूट
lovely
गया है, जो
talk,
छूट गया है,
lovely talk,
हम
brilliant
जो
talk.
जो
Yes.
छूट गया है,
Dr. Seema,
हमारी
brilliant
लाइब्रेरियन
talk.
बन रही है. या
बिल्कुल. ये राज
अब हम
राज
लोग
कहाँ चली
लाइब्रेरी
गई? Where is
She
Raj?
left. She left. She left.
अभी तो वेबिनार्स का सिलसिला चलता रहेगा, जारी रहेगा ब्रेक के बाद.
मजा आ गया लेकिन
So we can
Dr.
leave
Seema,
now.
मजा आ गया.
Yeah,
You
we'll
should
leave.
continue
We'll
such
leave.
सही में
webinars.
मजा आ गया, सही में.
कोई जा ही
It
नहीं
was
रहा
a
है.
true
बहुत मजा आया.
evening with
हमें पता नहीं चला
Isarians.
इतना टाइम
है ना?
पैनल का इतना टाइम
श्वेता,
पता ही नहीं चला कहाँ निकल गया.
श्वेता,
It was so
भारत, hey please offline करो पहले, हमें off air करो.
Stop this live streaming, please.
Please stop the live stream.
हम लोग लाइव स्ट्रीम हो रहे हैं. I thank all the doctors who had joined our
Yes, thank you.
this webinar.
Thank you, dear audience.
The audience.
Because of you, we could manage to stay online for so long. Vipin,
Can we
please,
become
can
offline?
we go offline? I mean, off air, off
एक तो
air.
लाइव स्ट्रीम बंद कर दो पहले.
Nobody.
अब हम बहुत नहीं, अभी भी चल रही है.
अभी भी चल रही है यार.
live है अभी भी.
चलो.
Thank you so much,
We
Seema
should
ma'am. Wonderful opportunity, and definitely you are one of the most knowledgeable, the most gracious and supportive, and you are a great academician, ma'am. And definitely you are like one of the gems of SR, and you deserve to win.